Good morning, good afternoon, colleagues. As Timo mentioned, my name is Christian Borgemeister. I'm the Managing Director of the Center for Development Research here at the University of Bonn, and one of the partners of our One Health and Urban Transformation graduate school. Other partners are the United Nations University with their Environment and Human Security Program, short UNEHS, and our friends and colleagues from the other side of the river, from the University of Applied Sciences, Bonn-Rhein-Sieg. Together with our international partners in Ahmedabad, the public health, in the Institute of Public Health in Chandigarh, then our partners from Accra, the Institute of Statistical, Social and Economic Research, ISER, at the University of Ghana in beautiful Legon, and last but not least, our colleagues from the University of Sao Paulo. We have been implementing this graduate school since about 3.5, 4 years now, and we're coming to an end of the phase 1, and that's the prime objective, the prime reason for our today's symposium. We're going to present back the results of the studies that we've conducted in the 3 international areas, as well as here in Germany in the Ruhr area, on One Health and urban transformation as a particular focus. So on one hand, it's, if you want to look back, but at the same time, we are also kind of moving or transiting into the new phase. We have been very lucky with our principal donor, the Ministry of Culture and Science of the federal state of North Rhine-Westphalia. They have granted us a second phase that will commence beginning of next year. So we will continue with this graduate school for another intake of new PhD students, and we are presently in the process of selecting these hopeful students. So we are going to move forward with this One Health topic, which is obviously in the present days of pandemics an incredibly crucial topic, and we are happy that we have the chance to continue with our graduate school with the research on One Health, particularly in urban contexts. With these few words, I would like to once again welcome all the participants to this symposium. I wish all of us some interesting discussions and exchange of ideas. And with this, I would like to pass on the baton to my colleague Katja Bender from the University of Applied Science here in Bonn-Rhein-Sieg. Katja, over to you. Thank you.
Thank you, Christian. So, yes, my mic is on. Yeah, thank you, Christian, for these welcome words and passing over. Also from my side, dear keynote speakers and panelists, dear participants, dear colleagues, and of course, most notably, dear PhD students of the One Health and Urban Transformation Graduate School. As mentioned, my name is Katja Bender. I'm director of the International Center for Sustainable Development at Bonn-Rhein-Sieg University of Applied Sciences, always a very long name. And also on behalf of my co-directors, Wiltrud Terlau and Martin Hamer, it is my great pleasure to also welcome you today to our symposium on One Health and Urban Transformation. And when looking at the number of participants, I'm quite impressed. There seems to be no Zoom fatigue, online video conferences fatigue. And I think this is also reflecting the growing importance of the topic of One Health within the scientific community, at the political level, but also beyond. And maybe let me just give you a brief example. We know that One Health is on the political agenda in many countries worldwide. Well, and if we look at Germany, there has been quite a development. The German Sustainable Development Strategy of 2016 mentions One Health, which is great. It mentions One Health one time, and in the context of health and nutrition. Now, at present, the government is in the process of further developing this strategy, updating the strategy, and the current draft version of the strategy for 2021 mentions One Health 3 times. This is quite an increase, and also the scope of One Health has grown considerably. It's not only health and nutrition, it is also global health, and it is also referred to within the context of health, environment, and climate change. So this is just one example how the concept of One Health is gaining more and more attention. I don't want to go into the details of today's contents because we will be discussing a lot about One Health, its meaning, its relevance for sustainable development, and also hopefully come to a mutual understanding of existing knowledge gaps. But here I would like to stress only one aspect, and I think that is an aspect which is of particular importance to me and also to the institute I'm representing, and it is linked to the cognitive implications of One Health. And to me, One Health is also important because it means overcoming fragmented silo thinking. And why is this the case? Because One Health is intrinsically an transdisciplinary concept, and there is no single one discipline which can deal with One Health in a meaningful way on its own. So to say, One Health urges us to join hands across disciplines and contexts and leave our disciplinary mental silos behind. And in this sense, it's also calls for collaboration instead of division. It is also democratic in a sense that people from multiple disciplines and backgrounds actually have a voice. And I think against the background of some recent developments, but also with respect to the multiple and interrelated societal challenges of the 21st century, this is exactly the type of concepts we need to deal with these challenges. Okay, and everyone who has been involved in interdisciplinary research probably knows that it might be exciting, it might be rewarding, but the way to results might also be difficult because we have to learn different languages and deal with different scientific mindsets. And before I conclude, I would like to use this opportunity to express my sincerest thanks to all PhD candidates of the graduate school and to Timo, Dr. Timo Falkenberg, the coordinator of the PhD school, because, well, honestly, I found you truly inspiring because all of you took or take interdisciplinary research seriously. And this is also demonstrated, I think, by the multiple joint presentations, publications in progress, or policy briefs, which have been produced throughout the last years. Thank you very much. And really, you're very inspiring in your effort and engagement. Okay, also from my side, special thanks to our partners from India, Ghana, and Brazil, because without you, the project would not have been possible. And of course, also many thanks to our renowned keynote speaker and panelists who will join us today. And last but definitely not least, it's always a lot of work to set up such an event, be it with physical presence or online. And I would like to thank the organizing committee, and here in particular, Ms. Sonja Keller, for all her dedicated work in efforts in bringing us all together today. So I'm wishing all of us an exciting and intellectually stimulating day ahead, and looking forward to this day. And now I would like to hand over to my colleague, Dr. Xiaoming Cheng, Director of the United Nations Institute for Environment and Human Security, UNU Institute, and Vice Rector of UNU in Europe. Thank you very much for your attention.
Thank you, Professor Bender, for the kind introduction. Good morning, everyone, or good evening or good afternoon. I don't know where you are in the world. These days, it's been a bit crazy. My name is Shen Xiaomeng. Shen is my family name. Xiaomeng is my first name. And I joined back to United Nations University Institute for Environment and Human Security in August, so I'm still quite new. I'm super excited to join our partners, Professor Bürgermeister of TEF, Professor Bender from Hochschule and this is a very important symposium. This is a very up-to-date topic. UNU is the academic arm of the United Nations. We deliver science-based solutions to the global challenges. And my institute deals mainly with disaster risk reduction, climate change, adaptation, and mitigation. And all these topics are very much intertwined with the ongoing current COVID situation. I would like to go back a little bit to 2004. That's the time where 3 world organizations, WHO, as you know, is World Health Organization, and the OIE is World Organization for Animal Health, and FAO, Food and Agriculture Organization. These 3 organizations have started working on a concept on One Health. They developed the One Health strategic framework, and since then, the One Health concept has been existing. But interestingly, none of these 3 members have focused on environmental health. So I'm really happy to see that we are now doing it. My feeling is really that's the missing focus on environmental health. This will change now because we are facing the pandemic situation, and it's all in all media. It's caused so much attention to everyone. So I think the attention should be turned more to environmental health to have a more holistic approach. As you may know, 70% of all diseases such as Ebola, Zika, and almost all known pandemics like AIDS, COVID-19, they're all zoonoses. And these microbes spill over due to contact among wildlife, livestock, and humans. These pandemics are driven by increasing human activities, like the very recent IPBES report points out. It's not enough, or it's even very much misleading to point fingers at wildlife, because it's us who have created all these activities, which significantly reduce the biodiversity, for instance. These are the reasons for causing increasing pandemic risks. The good news is conservation of ecosystems and stopping this kind of unsustainable human behavior, such as exploitation of high biodiversity regions. These will reduce our risks for pandemics. I see a lot of synergies with ecosystem-based solutions and climate adaptation, which focuses on very much climate improvement. So with all of this, I think we must work together, and we are already working together. This is a very positive thing, and to have this transdisciplinary and interdisciplinary approach. We need to work on joint goals for One Health, disaster risk reduction, and we should base all of these approaches on resilient and biodiverse ecosystems. I'm very happy to be here today and to join forces with the partners again. And I'm sure that our future research can really make a difference to the world. So I wish you all a very successful and inspiring discussion. Thank you very much.
Thank you, Dr. Shen. Thank you, Professor Bender and Professor Borgemeister for the kind introductions. It is my pleasure now to introduce our first keynote speaker, and he really does not need an introduction, Professor Jakob Zinstag-Kloppenstein. He is working at the Swiss Tropical Public Health Institute in Basel, and he, of course, is the person in One Health. He has been working on this topic since 1998, a long time before it became so popular. He has written the book on One Health, the One Health Theory and Practice of Integrated Approaches, which has largely inspired our graduate school and informed us. And it's a great pleasure to have him here today with us. And Professor Zinstag, the floor is yours. Thank you.
Thank you very much, Timo. Can you hear me?
Yes.
Can you see the presentation?
Yes.
Wonderful.
Great.
I'm very glad that everything works out properly. So welcome everybody. I unfortunately don't see the whole list of participants, but I'm very grateful and privileged to talk to you today, and thank you very much, Timo, for the kind invitation, and also thank you to Christian for being part of that. I think what Mrs. Bender and Mrs. Xiaomeng mentioned is critically important. I think in integrative work on health or integrative work in any disciplines, we are immediately attacked by the disciplinary scientists because they say this is not scientific enough. This is not cutting edge. And clearly we need cutting edge reductionist science. We still need that. We need that top science that looks for the new molecules and the new vaccines. That's absolutely necessary. But in the same time, as Mrs. Xiaomeng also mentioned, we need integrative approaches to science. So to convince the disciplinary experts we have to come up with very good theory and very good methods that are convincing actually the disciplinary scientists. And my talk is about that. I would like to introduce you to One Health methods that will help you to ask One Health, to respond to One Health questions. So, sorry, I tried to get this moving. Yeah, it works. So I would like to explain you, I just explained to you why One Health approaches are necessary, because the complicated problems of our current life, like climate change, like migration, like COVID, cannot be solved just by disciplinary scientists. I think if anybody needs to be convinced, COVID is definitely the compelling example. But we must demonstrate the usefulness of these integrated approaches. And then for this, I will introduce you to a theory about One Health, but also to methods, how we understand human-animal environmental interfaces, but also what is the social process behind, which is a transdisciplinary process. And then I will try to give you a few examples. That's all about my talk. And my talk will be made available to you. At the moment, I only send a PDF, but I can make it fully available. So, as Timo also mentioned, we have published, all what I'm saying is published in this book. And we are very happy that we are just publishing the second edition. about the theory and practice of integrated health approaches, and we make a huge step beyond just zoonosis to non-communicable diseases, and we have also a chapter on AMR. Our first edition is actually also available in French. For those of you who read French, this book can be freely downloaded on this link. It has been published by INRA in France. And we have also a book about the evaluation of One Health that has been published as part of a cost action of the European Union. This book can also be freely downloaded at Wageningen Academic Publishers. So this is about the documentation of One Health. Now, if you don't keep anything about my talk, make a picture of this slide. Keep this slide in mind. This is the essence of what I'm telling you. One Health has requirements. If we speak about One Health, for me, this has necessary and sufficient requirements. An absolutely necessary requirement, but not sufficient requirement, is the recognition of the inextricable linkage of human, livestock, companion animal, and wildlife health and the environment. So, Dr. Xiaomeng, we completely include the environment in One Health. We are far enough. But that's not enough. That's not enough for being sufficient for a One Health approach. We need more than that. And sufficient requirements are that we demonstrate an incremental benefit of working together, an added value of health and well-being of humans and animals, or financial savings, but also better social resilience and environmental sustainability from a closer cooperation of human and animal health and other sectors. Timo, can you still hear me?
Yes, yes.
Good, good. So I continue. It would be a shame if I talk to the window. Doctors and veterinarians and other scientists, all of them can work in their corners, in their disciplines, and they can make humans healthy and animals healthy. But if they work together, they can make more humans and animals healthy, and they can save more money as if they work alone. This is the essence of One Health theory. And if we can prove that incremental benefit, especially financially, then that is for me sufficient to convince a minister. A minister will only listen to money. So if we can show that working together saves money, that is the convincing argument for One Health. But it must also be socially acceptable and environmentally sustainable, of course. We remain in the triad of sustainability. So, as I said, that is the #1 theoretical foundation. The #2 theoretical foundation is that we have to work in a democratic and participatory way. I thank you very much, Mrs. Bender, that you mentioned that. We must consider academic and non-academic knowledge in the research process. Many people with, whom we work with, and I will show you examples, have not an academic training, but they are experts. I will just show this to you on examples with mobile pastoralists in Africa. So we want to value contributions of all stakeholders in the generation of knowledge. I think there is also confusion about the use of the words interdisciplinary and transdisciplinary. Interdisciplinary is if we work between two academic disciplines and we generate a common epistemological framework. That is interdisciplinary. So, for example, if we work between medicine and the humanities. But if we work between science and society, between academic and non-academic actors, this is what we call transdisciplinary work. And I actually identify emerging career profile. I encourage strongly young scientists to become good in their discipline, but then open up to interdisciplinary and transdisciplinary approaches. To demonstrate you how this takes place, I show you two contexts. On the left, this is under a tent on the shore of Lake Chad in 2005. And on the right side, this is under a tent 100 kilometers north of Timbuktu in North Mali in 2006. Unfortunately, today, in neither of the areas we can safely go, because on the left side, this is dominated by Boko Haram terrorism, and on the right side, this is governed by Al-Qaeda terrorism. So this shows you that it is very dangerous at times to work in a transdisciplinary way. So the essence is that we bring together decision makers. Here on the left side, you have the chief veterinarian of Chad. On the right side, you have the political authorities of Timbuktu, and the man with the yellow turban is a chief medical officer of the hospital of Timbuktu. And on the right side, then we bring together the concerned population. On the right side, you have the Tuareg communities. On the left side, you have several groups of pastoralists in Chad. And we bring together the scientists. And in this framework, we can, if we are able to create an atmosphere of trust, we can enter into a dialogue and we can co-produce transformational knowledge to solve practical societal problems. That's the definition of transdisciplinary work. I'm the president of the scientific advisory board of the transdisciplinary network of the Swiss academies, and I invite you to visit the homepage of transdisciplinarity.ch, which has a lot of transdisciplinary methods and toolboxes how to do this kind of research. I was also a member of an OECD working group. Actually, I was co-chair that has just published a policy brief on transdisciplinary research, the promotion of transdisciplinary research worldwide. You can Google it and you will find it. So transdisciplinary approaches are part and parcel of One Health research. Without that, we cannot solve practical problems that appear, or societal problems that appear in a context where we have to solve it with One Health approaches. And you agree with me, many of the people on these pictures don't have an academic training, but they are experts. Most of us would not survive 2 weeks in the desert of the Sahara, but these people survive since centuries. So they are experts and they have truly very important knowledge that we need to understand. Let us continue. We were also able to establish a dialogue, a transdisciplinary participatory dialogue with other epistemic systems. Here we talked with Maya healers on animal health and on human health. So we have boundary objects like the sick chicken on the left side, and on the right side, a patient that we discuss between Maya medicine and modern Western medicine. There is a link about a 20-minute YouTube video that you can watch how we establish and we operate this dialogue. I cannot go into more details at the moment, but let us move on. So the essence in One Health is that we understand the animal-human interface, and I would expand it to the animal-human environmental interface. Here you see 3 examples of dog-human interfaces. On the left side, you see a family in N'Djamena, the capital city of Chad, with their dog. This dog has a clear role as a watchdog. and he is currently vaccinated against rabies. We will come back to that example. On the right side, this is a man having 3 dogs tied to his bicycle. He will go and sell these dogs for food. These dogs are eaten in southern Mali, where some people eat dogs. So these dogs have a commercial value of about 10 euros. And in the middle, you have Paris Hilton with her pet dog. And this dog is neither a watchdog nor will he be eaten, but Paris Hilton apparently keeps it for company. So these are 3 different interfaces that we need to understand in detail. So the detailed understanding of this interface is a necessary condition for One Health, but it is not yet sufficient. To be sufficient, we want to show that if we study humans and animals in the same time, we can generate an added value in terms of health or financial savings. So let us see examples now how you can prove that. So we need methods. We need methods that study humans and animals in the same time. So the first method I show you is a linear statistical interface. So we regress human health to animal health. We could also do the inverse. We could regress animal health to human health. But in this study here, we studied the seroprevalence of brucellosis. This is a bacterial zoonosis that causes abortion in animals, but infects humans and causes a difficult and long-standing fever disease in humans. We wanted to know how high is the seroprevalence in humans and which are the animals that likely transmit it mostly. In Kyrgyzstan, there are mostly sheep, goat, and cattle kept by the farmers, but we don't know which is the animal that transmits it most to humans. So we sampled sheep, goat, and cattle here and humans in the same households. At the end, we have collected 1,800 samples from cattle, 2,000 from sheep, 1,200 from goats, and 1,700 from humans. And we applied different serological tests. Top left, this is Rose Bengal test. This is a bedside test. You can apply it in the field. And we did also ELISA tests. ELISA test is a laboratory test. And ultimately, we regressed human seroprevalence to animal seroprevalence. And this was a representative cluster sampling study in the whole of Kyrgyzstan. So this was a nationally representative study. And the regression showed that compared to goat and cattle, sheep was the most significant influencing factor for human seroprevalence. We had even a negative relationship to cattle, and for goats it was not significant. And we confirmed this result with molecular typing of aborted brucella that we isolated from aborted fetuses. So we cultivated organs of aborted fetuses, and we could show that most of the strains we isolated from sheep, some of cattle, and all was Brucella melitensis. So we could confirm the statistical observation with molecular characterization of the strains. So this is a One Health study because it shows in one go, it shows the zoonotic source of a human disease. And we saved a lot of money because we did the study jointly. If we would have studied humans alone and animals alone, it would have costed twice the amount. And we could not have identified the zoonotic source. So in one go, we generated more knowledge that we could have generated alone, and we saved money. Therefore, this is an example of a One Health study. Next example, now it becomes more complicated. We wanted to know if mass vaccination of livestock against brucellosis in Mongolia was profitable to the national economy to prevent human brucellosis cases. You all know that the socialist period ended in 1990, and after that the health systems in Mongolia collapsed and brucellosis reappeared very rapidly. And all experts recommended to WHO that Mongolia should again start mass vaccination of livestock. They did this successfully during the socialist period. This is the picture that you see is from 1974. And in this period, with help of the Comecon countries, Mongolia almost successfully eliminated brucellosis by mass vaccinating of livestock. So we wanted to answer this question of the effect of an animal vaccination on public health. But now this situation is more complicated. We cannot solve it with statistical methods. We need dynamic methods. So we have a nonlinear mathematical interface. So we have to write coupled differential equations. Here you see the flow chart of the coupled differential equations of animal to animal transmission and animal to human transmission of brucellosis. So the oblique arrows that you see here, they simulate the animal to human transmission from small ruminants and from cattle. I spare you the mathematics, but this is based on coupled differential equations, and here is the economics. So for intervention costs of $8 million to vaccinate 25 million animals, we have only benefits of public health benefits of about $3 million. So if you would be Minister of Health in Mongolia, you would say it is not profitable. But we interviewed also 250 patients about their private cost and income loss. And we simulated also the livestock production benefits from reduced brucellosis. Brucellosis in livestock causes a reduction in productivity because of the lower fertility. That leads to less meat, less milk, and less live animals. So if we vaccinate the animals, we can avert all these losses. So if we sum up all the benefits from mass vaccination of livestock, the total societal benefits are 3 times higher than the intervention cost. So you can show that if you don't take a sectoral perspective, only public health, but you look at the whole of society, you can show that the intervention in the animals is profitable to whole of society, while it is not profitable to public health alone. That's another One Health example that shows if we extend our perspective to the whole of society, interventions that are not profitable to public health alone are profitable to whole of society. But we need methods that prove that. That's why we need dynamic coupled differential equations to prove that, and linked to cross-sector economics. So we can show that the intervention in animals and humans divided by the intervention cost are more profitable than the intervention only in the public health. And also the cost effectiveness is better. If we intervene in the animals, it costs only $20 per DALI averted, compared to interventions of more than $100 per DALI averted if we only treat the humans. Similarly, rabies is a similar case. Rabies is also a type 2 disease that is directly transmitted to humans, but it is not transmitted between humans. And we can ask the same question for rabies transmission. is it profitable to mass vaccinate dogs to prevent human rabies? You could argue I intervene only in the humans that are bitten by rabid dogs, and that is less costly. But this is exactly the question in the long run. We can apply a similar model. I spare you the mathematics. This simulates transmission of rabies between dogs and from dogs to humans. And we can do, and actually we did this work in N'Djamena, the capital city of Chad. For 2 years, we vaccinated 20,000 dogs. And we did this with mobile fixed post vaccinations. And here is, you see how quickly the transmission collapsed. The brown line is the number of infective dogs and the blue line of exposed dogs. And we could keep N'Djamena free for 1 year. Of course, that area was too small to keep it free for longer time. But here is the economics. If you intervene only in the humans, you have increasing cumulative cost. If you intervene in the dogs, you have higher cost at the beginning, but because you interrupt transmission, the curve after that rises with a lower slope. And we come to break even after about 6 years. So on a time horizon of 10 years, it is less costly to intervene in the reservoir if the disease is not reintroduced. So the cumulative cost of intervening in animals and humans is less on a horizon on 10 years than the interventions in humans alone. So this is again a classical example that an intervention in a One Health approach is less costly than an intervention focusing only on public health. Now, the big problem today that we have is, of course, corona. And corona is not a class 2 disease, it is a class 4 pathogen. It is probably only once transmitted to humans, and then it quickly transmits between humans. So here we need actually a One Health approach to develop integrated surveillance. For the prevention of future pandemics, we must know what is going on in the animal reservoir before it jumps over to humans. We just published this paper together with colleagues from Shanghai, from the Institute of Parasitic Disease, which is part of China CDC. And the main feature here is that, and actually this is not new, this is a schematic that was published by the World Bank in 2012 already, saying that the earlier we detect a pathogen in the environment and we prevent its outbreak, the less are the cost. You see here the cumulative cost curve. If you wait until it is in domestic animals, the costs are already much higher. And if you wait until it is in humans, the costs are even more higher. So the current COVID outbreak is the very best example, and it is way over the expectations even of the World Bank in 2012. So the future of disease prevention are integrated surveillance systems that survey potentially emerging disease in the environment, in vectors, in mosquitoes, in wildlife, in domestic animals, and in humans. The problem is today, most of the surveillance systems are not integrated. They are either in humans or in animals. So the future is really fully integrated surveillance systems. And one of the good examples is the Italian West Nile virus surveillance, which looks at mosquitoes, wild birds, horses, and humans in the same time. And in this way, they can show already financial savings if they inform each other on the occurrence of the virus. The problem is not so easy because the big problem is that we have very low biosecurity in a lot of the livestock production systems, and also we have very poor animal welfare. I recommend you to read that paper that I just that I just showed you. It is all described in that paper. To close my talk, I would like to summarize in a Venn diagram integrative health concepts. So the green ellipse is animal health, and the red ellipse is public health, and the overlapping dimension is One Health. Clearly, not everything is One Health. There are pure public health issues, they don't need One Health. And there are clear animal health issues, they don't need One Health. But everything at the intersection and a little bit going beyond into the social ecological system, this is One Health. And also what Mrs. Xiaomeng mentioned, ecosystem approaches to health look at the human environment systems, so the social ecological system. We have coined in 2011 already the term health in social ecological systems as an overarching, extending concept going beyond pure One Health. And ecosystem approaches to health are clearly embracing One Health. And the last concept is planetary health. Planetary health looks also at the big changes like climate change and all these things, but planetary health explicitly does not address animal health, as far as I understand it. So with this, I close my talk, recommending you to participate in this online course on One Health, which is currently open and running on the platform of Future Health. Thank you very much for your attention.
Thank you very much, Jakob, for this great presentation and insight into all the work that you have been doing. It's really quite astonishing always to hear all the different things that you have done and have done for One Health. I want to remind our audience of this Q&A function, because I think right now no one has used it. But I think in the interest of time, I would say we move ahead to our second keynote speaker. Professor Zinstag is going to be back with us in the afternoon at the panel discussion. And I think then we can also pick up some of the questions regarding these approaches and One Health in general. So once again, Jakob, thank you very much for taking the time. I know this One Health Day is always a busy day for you. So thank you very much for being here with us. And for all the students, once again, the slide that's still showing, very, very highly recommended to have a look at the courses that are offered free of charge even on One Health. So next on our keynote speaker list, we have Professor Dr. Jörg Heukelbach. He is a medical doctor. He has 20 years of experience in infectious disease epidemiology. He has a diploma in tropical medicine and hygiene, a master's degree in international health, and he holds a PhD in pharmacology. He has extensive experience working as a consultant in over 15 countries around the world. And most recently, he has been involved in research and teaching activities in Brazil, focusing mostly on neglected tropical diseases as well as other poverty-related diseases. He has been a strong advocate for One Health in the context of South America and also Sub-Saharan Africa. Recently, he founded the One Health Institute Heukelbach, in which he specializes in providing interdisciplinary consultancy and capacity building services. So it is our very great pleasure to welcome Dr. Heukelbach to share some of his practical experiences from the field. So Professor Heukelbach, the floor is yours.
Yeah, good morning, everybody. Thank you very much for this introduction. Just the first question, as always, can you see the slides?
Yes, the slides
Okay.
are there, and we can hear you also.
Perfect. I'm very happy that Jakob Sinstag has made this rather theoretical introduction, because I would like to focus on the practical aspects of One Health. So what really happens in the field, and what can we do if we are working in the field as doctors, as psychologists, as veterinarians, and how can we make a change somehow at the grassroots level in collaboration with communities, and also with interdisciplinary with other disciplines in the academia. So we know this, all of us, we know this here. I was like quickly go into this web of causation, or web of interaction between the different disciplines here, and just like the people, society, as already discussed, that would most people think of the inadequate living conditions, about water, conflicts and wars, migration. So this interaction between disease and antimicrobial resistance, environment and climate change would include, especially if you think of neglected tropical diseases, the spread of new vectors into new areas, the mobility of people, the deterioration of soil qualities, and these issues. Animal health, we think first of zoonotic diseases, of livestock farming, intensive livestock farming, with all these problems resolved, and interaction with wild animals. Wherever we see, especially in Brazil, wherever there's destruction of rainforest, wherever there's urbanization, wherever people go into the more and more into the wild, and more interaction between people and wild animals, the disease come up. So if it is a new construction site of a large dam, if it is a new road, or if it's just simply destruction of the forest for livestock farming, for other issues. And last but not least is the governance and health systems, which is extremely important. Here we have the political will, which is especially, as most of you know, in Brazil, it's a rather difficult issue now, that it is stuck to ideologies, to raising regional nationalism, to decreased research or funds on poverty-related diseases, and so on. So within this context, what does it mean in practice? How do we control disease? What do we do? And if we go into this is, for example, an urban slum in a major city in Brazil, a city with almost 3 million inhabitants in northeast Brazil. And if you just go up the road, you can see these conditions. So here we have a complex issue of what does it mean living here. It's not only one disease, it's many diseases, not only one cause, it's many causes. It comes from poor access to good education, to migration, to increasing population density, to cultural aspects, also how people behave here, malnutrition, resistance to diseases, no clean water facilities, and so on. So how do you start here control diseases without, well, changing the system? Now we want to change the system, but you cannot just stop poverty here. So if you go inside these houses, you see that these children, these girls, they have to take care of their younger sisters. They're in a hammock here. This is so. So this room here is a child's room. It's a kitchen. It's at night people just hang up their hammocks and would sleep there. It's a lot of aggregation. You can see all these animals coming in at night, and the boys playing here in the environment, in this urban environment. So if you look into the houses again, these girls don't go to school. They have to take care of their younger sisters. So this is a vicious circle. We all know this vicious circle here. This is very similar in many communities. And if you work in One Health, also, it's, for me, it's very important here, and we have done a lot of work there with a foundation that we have we have created in these communities is all the education. So you have to work on education, you have to work on health and education, and all the other aspects we have discussed on One Health. So animal health, just another example here. This is a dog from a indigenous community in central Brazil. And these dogs, they sleep together with their people in the same hammock. And you can imagine that there's a lot to do here in terms of animal health, in terms of human health, in terms of transmission to reduce disease in this extremely affected indigenous communities with extremely high disease morbidities in terms of infectious diseases. It's really impressive how these communities suffer from different infectious diseases at the same time. I would like to make a cause here, our case for a disease that maybe many of you don't know. Most people from Africa and South America should know, which is Tungiasis. This is one of the most neglected tropical diseases. It has been only recently been recognized by WHO as a neglected tropical disease after strong advocacy we have done here. And it is, for me, a paradigmatic sample for One Health, because you can do a lot of things here. You can make a change, and it involves the wild animals, domestic animals, human people, and the environment. So mostly you see here just a single lesion. This is almost 1 centimeter here in diameter. But if you look, what is that? It's basically a flea. So this is a flea, a male flea feeding here on a rat we have collected from an urban slum. And these fleas, the female fleas, they would penetrate at some time into the epidermis. So you can see this flea in status of penetration. Half of the flea has been penetrated already. And then after some time, after full penetration, they start creating their eggs, and they have hypertrophy. So you can here see the abdominal segment, the first segment. This is the last segment, and this here all is the abdomen of this hypertrophed flea with about 200-300 eggs that are going to be expelled in the environment. So this flea is penetrated mostly on the feet. The people walk around, expel the eggs in the environment, and in the environment, the flea develop to larvae, to pupae, and then penetrate again people. So it's a complete lifestyle. It's a complex life cycle. The problem is not one lesion that you have. The problem is that if you go to different environments, so this is a rural environment in Nigeria, but you also will find this in urban settings in Northeast and also in South Brazil, and also in Sub-Saharan Africa. The problem is the penetration of many fleas at the same time. So this boy here never had a tetanus vaccination. This boy never had gone to school. He suffered severe stigma from the community, so never left out his hut. So he would be infected in his hut all the time. So this is a severe problem in terms of social sciences, in terms of stigma, in terms of prevention, in terms of disease, bacterial superinfection, and so on. But if you have a look at the dogs, at the cats, they also are infected, and they are companion animals here. You see here all these lesions. There are dozens of penetrated fleas expelling eggs in the environment. So this is an old lesion. There's an old lesion here, expelling in the environment the eggs. So the dogs walking around rats. So this is a domestic rat, but you also find rural rodents where we have collected them. They're also infected to a high degree. Anteaters and everything that you can imagine. All the mammals are infected here. So this is important. So you can see that it's very complex here to control disease, especially in the absence of any really approved treatment, and with all these different causes on different relations. So this is inside the house. So these people get infected in the house. Here you have, in this sand, you have collected this sand, you will find hundreds and hundreds of larvae of fleas, of pupae of fleas here, hundreds and hundreds of larvae. So basically, why it is for me so important for One Health here. We have the human cycle, we have the domestic animal cycle, we have the wild animal cycle, we have relation with the urbanization, with the migration of people, the offer stages. So the important is the environment, the people, the environment, and also what happens inside the houses, outside the houses. We have a very strong link to poverty and other social determinants, and also the behavior of people is important here. Do people walk barefoot? Where do they rest? How do they behave in after infection? Do we take out their fleas? Do we work on? Do they infect themselves with bacterial infection? Do we have problems, for example, here with HIV transmission because of sharing of needles for extraction of fleas, and so on and so on? And we have observed that the climatic conditions are extremely important here. We have a strong seasonal variation, and we also have a strong relationship with certain climatic conditions here where these fleas occur. So we need a multidisciplinary approach. We need different fields. We need a interdisciplinary approach, but also a transdisciplinary approach, as Jakob Sistak has explained. So including not only entomologists and medical doctors, but also biologists, anthropologists, and so on, veterinarians and public health professions. So I would like to give you a small example here of a study in Nigeria, in rural Nigeria, in Lagos State, which we have performed several years ago without a lot of funding. So this was really out-of-pocket funding here, but we managed to reduce the prevalence in this extremely affected community. So in the first cross-sectional study, we have identified that many houses had sand or clay inside, and the population, the attributable fraction of the population, so the percentage responsible for infection here was more than 70%. Behavior, the people, where do people rest outside the houses? It was also very important at certain resting places, people who did not use footwear, and also the presence of pigs roaming in the community. So the prevalence in pigs was extremely high. So this was a community, not a Muslim community. It was in southern Nigeria. So the situation may be different in other cultural contexts. But in this community, the pigs had a very important for transmission. We have observed that in Brazil, in many urban environments, the dogs are more important. So what have we done? We just talked to the chiefs. And they were very much impressed by our data in meetings, and then they collaborated intensively and said, we will ban the free-ranging pigs here. So they say nobody is not allowed to let them range around, or don't keep pigs. We tried in educational settings to increase the use of footwear, which was not that easy. Arranged some cement and concrete at the floors, and try to increase the environmental hygiene of the people, the behavior of the people. So you can see this is here the compliance of the population. So the easiest compliance here was really, this was quite a surprise with the free-ranging pigs, because this was very easy here in collaboration with the community leaders and with other people. So it was very, very much welcomed, and it was quite easy to convince people of this benefit. And there's also additional benefits, just other diseases transmitted by the pigs. So this was quite easy. The use of footwear was a little bit more difficult because there are cultural aspects that play a role, and we concreted a lot of floors inside the houses, which also reduced the transmission. So this is the school in this community. This is his school teacher. He's inspecting his feet for any penetrated fleas. And he told us that every morning when the kids come to school, they have a look on the feet and take out the fleas. So the teachers play an important role here, but you can also see the environment in the school. So this is the school, this is the floor in the school, and we have really seen the fleas hopping around here, jumping around. So the environment, the school environment is really increasing the vicious circle of transmission here, because the kids come together. Many kids, the kids have a prevalence of more than 50–60% here. They excrement the environment, and then the transmission takes place. So every morning the teachers will take out these fleas, and you can see that the hygienic conditions are well below standard here, that this is also a high risk for any bacterial superinfection, for tetanus, and for any other disease. So this was also a very important approach here to improve this situation. So what happened 1 year later? So the prevalence in the overall population was about 45%, as said, in the children maybe 60–70. And then we managed to reduce this to 20% after 1 year. And this intervention was done right after the cross-sectional study. So it was a very sustainable intervention, and the total number of lesions was reduced by 80%. What does it mean? This means that the morbidity was reduced. So people have single lesions. They don't have this severe feed, as I've shown you. In the beginning, they have single lesions, and this was reduced by 80%. So with quite simple methods here, quite simple investments and low investments, we managed to, on a sustainable manner, reduce the prevalence. What is 12 years later? What is now, the situation now, today? So the people did not forget about the epidemic and then, or about the situation before. And there has even been a spillover effect. So other close by communities in the region followed this intervention because they have seen the effect, and they mainly prohibited the free-ranging pigs, and also the prevalence in the other communities was reduced. So we have here kind of multiplying effect, a spillover effect. No severe morbidity is seen, and we also have managed to increase advocacy at the WHO. So this is basically when we go back to this chart of the factors involved, and we look at the details. So if you look at the red terms, when we look at tungiasis, these are basically the issues I think were important for transmission of tungiasis, and all these complex factors, interligated factors, you can relatively easily control in communities on a long-term level without a lot of investment and without a lot of other issues. The animal prevalence also reduced there. I did not show this data here now, but the prevalence in animals was also extremely high. This also reduced. So you also have here an effect for the animal health, for human health, and all these factors here where you work on. You have the problems with people don't go to school and they're infected, mainly because of stigma. You have increased access to education. We have here the importance of migration, people migrating from one area to another, the problems of malnutrition and living conditions here, and the spread to new regions and the environmental pollution causing these problems. One very important issue here is really, in fact, the health policies that we have still, as said also in the beginning, the problem of silo thinking, which is getting much better in the last time, that people still hold on to silos, and politicians hold on to their ideologies. So many times we have problems with disease prevention control because of not evidence-based ideologies. Coming back to Brazil, again, in Brazil, this is currently a huge problem, that the health system is not based on evidence, it is based on ideological thinking with devastating consequences for the weak and vulnerable populations. This is currently in Brazil with the privatization of the unified health system, which has been planned. There will be a destruction of the unified health system, which will cause extreme problems to the underprivileged populations, and this will go on for years. So in this context, we still can do something without a lot of political approach on the central level. So just to close with that, to make a point, we it's possible to control effective and sustainably diseases at low cost, but we have to consider really that has to be a communication between sectors and regions. We have to address the silo mentality. Priority setting is important in politics. The local communities, NGOs, traditional leaders are paramount here, as also Jakob Sinsas has shown us in his images from Mali and from Chad. These are experts, these people, they know very well. I have learned so much from these people about Tungises in the beginning when I started working with that. It's impressive. These people are experts in many ways. We have to join forces, and this is very important, with other NTD control programs, with other disease control programs. So this is integrate the actions, the activities. If you go to these communities, if you have access to the people, it does not make sense only to work on one disease. We have to include other diseases. So each setting is different. You may have settings where we have the wild animal more important. You may have settings where the domestic animal is more important. You maybe have settings where the pigs play a major role. You may have settings there girls are more affected than boys because of different behaviors. You may have fishermen communities where mainly the women are affected. So urban communities are different from rural communities. So this is all this very differently. The living conditions play a major part here, and we need more data. Research is needed. We have only very punctual data, or very data which is very rare, and especially from Africa, it's increasing now. There have been more and more studies, but this is very important here to increase also advocacy and financing at the central level. So thank you very much. I hope I took my talk a little bit shorter here because we're running out of time, but I'm open for any discussions, and I'm happy to discuss with you any future points regarding disease control in poor communities.
Thank you very much, Professor Höckelbach, for this talk. Very great insights into your practical work, and demonstrating very clearly how One Health is actually at the heart of many diseases that are poverty related, and also the neglected tropical diseases. This interaction between animals and the humans, embedded in that social cultural context, is very important to consider. I want to once again point out the Q&A function, because right now I think it is not being used very much. There's been a few questions that were addressed to Professor Zinstag during the talk. But in case you have any questions, please use that Q&A function so that we can discuss. I'll give you a few moments in case you have anything to quickly type them out. And as a side note, those questions can also be upvoted. So if in case you see any questions there that you yourself find interesting yourself, you can also just give it a thumbs up, and with that increase the likelihood of those questions actually going to be answered. Right now, I guess there's nothing yet. We still have a few minutes. I mean, technically we're moving now into our break, but I just want to give a few more seconds for anybody who might want to give a.
Maybe somebody can share his experience or her experience working on the grassroots level here, because this is more practical approach, and we now had the theoretical approach, we had the practical approach. It would be quite interesting to hear experience from other people working on the grassroots level, how they address or how they try to implement somehow One Health aspects into their daily work without, maybe they don't call it One Health, they just do it this way. I've seen this a lot of people in the field. Also, another example would be leprosy. Leprosy control is also quite quite impressive that because people are very experienced work in this area, and they have to work interdisciplinary. And this is quite interesting. Maybe somebody can share here his experience.
In case you want to share it, you can use your raise hand to get the right to contribute something.
That's one.
Yeah, this is. Do you have something to say? I mean, this is just a thank you, I guess. I mean, from our experience, in terms of this bottom-up approach to One Health, this is actually one of the things. Here we have someone who wants to contribute. So I'll allow to talk. So you can now unmute yourself, Mr. Osman.
Hello, my name is Tasnim Osman. I'm PhD student at ZEF. My research topic is about screening for arbovirus diseases in Kenya. So my main objective in this study to screen for arboviruses. So I have to collect mosquito from different farm and screening if there is arboviruses in this area or not. When I go there for the field, this is my main plan. When I go there, I know that I have to collect some data about animals and human because you know that arbovirus disease is zoonotic disease come to animal and human, specifically Rift Valley fever. So I go to the animal health centers and I ask about if there's any information about the diseases and how the people here know about if there is any record about this disease, about arboviruses and specifically Rift Valley. And then I go to also and I ask community how can eliminate the disease if the disease happen and how the community know about this disease. And I'm pushing and I'm surprising that the community even don't know this type of diseases. Just know if there is fever, that means this is malaria. And for animals, they said for me that if they feel there is one animals have symptoms like this, they directly kill the animal without knowing anything, because they know that if they know there is disease will spread for all animals and will kill animals. And also
I would stop you there. I think we're going a little bit off topic here. No, we want to keep it in terms of the experience, and I guess now you've been going quite far. We got a couple of
I've seen that here. Yep.
Couple of questions coming in. Maybe the question about the ecologies of the vectors. I mean, that would be something I think that's related also to the question or to the comment that was just there.
Yeah, maybe quickly to the other viral diseases. I mean, this is also a very good example of One Health, because you have the vector, you have the different diseases you can integrate. You have Zika, you have dengue, you have other diseases, chikungunya, maybe co-infections, and the best approach in terms of control is really work on the vector, work on breeding sites together with communities. So my experience, if you talk to the communities, they're extremely open. If you show them the breeding sites and they collaborate on this. So this is really also a very nice example for One Health, actually. So Ana Maria Perez asked you about the vectors. So maybe I have been misunderstood. There's no vector involved. So the flea is not the vector. The flea is the parasite. I don't know if you mean with the vector the parasite. The different ecologies is here that you need certain climatic conditions so that the flea can proliferate and that the eggs would develop in the environment. So if it's too dry and too hot, they don't develop. So you usually don't find a lot of transmission pressure in sunny sides. It's mainly in the shade, in the shadows, inside the huts, in indigenous communities, in the Moluccas, in this huge housing devices of the indigenous communities. So there you find a lot of transmission, and there also these are also the places where people and animals come together. So in terms of ecology, and it's a more microecology here, a level that you have high risk areas of transmission. This is what also was reflected by our risk factor of preferred resting site in Nigeria, for example, where people would rest and where people would be infested. So this is really, we also have done some works on collection soils and samples from different areas, and it really depends on the humidity of the sand and on the temperature here, and on some biological material where a contamination of the sand with some biological material where the larvae could feed on. This is also important. So this was the question. There was one question about pushbacks regarding traditional beliefs, traditional medicine. No, not really. Can you still hear me? Yes?
Yes, yeah. Yes, we
can hear you. No, not really. There is a lot of traditional beliefs and a lot of also traditional medicine. We have also done some focus groups and some interviews with traditional healers. This is extremely interesting how are the beliefs about the flea, about this, but mostly these, because you can see the flea and you can see the penetration. The people are quite aware about the transmission cycle, about how do you get the disease. In terms of traditional medicine, there's a lot of different treatment approaches, which is quite interesting. There are some people who would spray some substances inside the houses to reduce transmission. Some only do water, other do cassava extracts, others do other issues. So there's a lot of traditional medicine, and we also have learned in terms of therapies and non-therapeutics that, for example, the coconut oil, which seems to work quite well in terms of treatment, also in terms of prevention here. Is there another question?
There is one more about the hygiene interventions. But I think that do you have any idea why people thought it is hard to follow hygiene measures, and what could be done to improve the situation?
Yeah, this is not easy. This starts with the waste collect. So you usually find a lot of waste in the compounds scattered around, but there's no waste collection in these communities. So this is a kind of very complex issue here, because with the waste you have the biological material at all that the larvae need. You also you increase the number of rats and mice and other animals that are the reservoir for the disease. So this is quite difficult here in terms of make a cleanup of the compounds and also inside the houses. These people are, you have to imagine, these people are suffering from the disease. These are the poorest of the poorest. If in an urban environment, in a slum in Brazil, 60% in the community I've shown, 60% of the children don't know their fathers or don't know who's their father. So the women have, the fathers often are in prison, have died because of violence, or alcoholics, many of them. So the women have to take care of the family, they have to work, and they have to do the washing and the food and everything. So they come home from work in the evening, have 5 children, all of them full of tunga fleas and sand fleas, and then as soon as you get out a needle, the child would cry and they to get out the fleas. So there's a kind of really complex situation. So in this context, how do you tell people that they should keep their compound clean? It's not easy. It's very complicated. So it's extremely most vulnerable populations suffer most here. The problem is not one lesion. The problem is really the number of lesions. You have lesions on the hands. You have children that cannot grip because they have their hands full of Tunga lesions. So these are the high problem families, and there you have make special interventions here. I want to ask, there's a side effect in the antibiotic application on domestic animals, and it will be difficult to consume animal food, especially milk or meat. Can you say what ill effects we face by humans and how can we care them for human? I don't know if this question is for me or is it for Jakob Sinstag? The question by Dr. Debjani.
Yeah, I'm actually not sure if who it was for, do you have some? I think generally speaking, of course, there is an effect.
This is a major problem in communities and countries, for example, Brazil, where you have extreme high use of antibiotics in livestock farming, and you have the problem of creating antimicrobial resistance. This is known. This is not a new issue, and you have also these antibiotics in meat and milk. As far as I know, there's also one study going on in one of your students, Timo, about this and how to cope with AMR in the environment. As far as I know, this is a major issue in India, where you have the problems with this in the environment, also partly caused by the pharmaceutical industry. So this is a very complex issue. Maybe somebody else can here comment on that.
Yeah, I think we will come to the AMR side a bit later. There's now another one coming up with AMR in the environment. I would say that we also take this for a later point. I think at this stage we are already quite advanced into our coffee break, our virtual coffee break. So I would thank you again, Jörg, for your presentation and for the discussion. Maybe if there is going to be more questions that come out throughout the day, there's a possibility also for you to answer some of those in writing. And of course, people can visit your website and maybe get in touch to you also via that. So thank you once again for the presentation and your insights. I would say we now move into our coffee break. We'll shorten it a little bit so that we stick to our time plan. So we take 15-minute break, come back at 11:45, and in the meantime, if you want to get some insights into the different research regions that we have been working in our graduate school, I have shared a link into the chat where you can find our virtual poster exhibition, and the information is also written here on this slide that I'm sharing now. So with that, I would say let's take a 15-minute break, get your coffees, and let's get energized for the next part of our symposium. Thank you very much again, Dr. Heukelbach, for the presentation, and thank you for those that ask questions.
I share my email here in the chat. Okay.
Yes, great.
Perfect.
Now we come to the next part in our program, and this is the framework presentation. So I will share my screen now with you, and then we're going to zoom ourselves down into the conference room of CEF and start the presentations. Hello and welcome everybody to the One Health Symposium of the Forschungskolleg One Health and Urban Transformation. I'm Dr. Timo Falkenberg. I'm the coordinator of the graduate school, and along with the doctoral students Anna Brückner and Ana Maria Perez Arredondo, we are going to walk you through the concept of One Health in our graduate school. Initially, I am going to tell you about who we are and what research topics we cover, and our One Health concept that we have developed. Anna Brückner is then going to tell you the conceptualization in the urban context that we have developed. And lastly, Ana Maria Perez Arredondo is going to introduce you to the policy framework that we have developed that we want to use to communicate with policymakers and practice partners. So who are we? We are a graduate school that is funded by the Ministry of Culture and Science of the state government of North Rhine-Westphalia. And these Forschungskollegs, there's 6 of them in North Rhine-Westphalia, and the ministry is funding these to promote transdisciplinary research for the development of solutions to the complex problems of the 21st century. So what does it mean? We are trying to always foster cooperations between different academic disciplines as well as economic, political, and societal actors. So essentially, we are emphasizing the practical implementation of our research results. We're working together with practice partners, mostly from the political sphere, also from the societal sphere, CBOs and NGOs, to think about what topics are actually of practical relevance to those in the context of One Health. So who are we? We are 13 doctoral students, and we're working on 3 thematic clusters. The first one, how to ensure health-sensitive food systems, how to develop One Health governance systems, and how to promote health through the management of water systems. On the bottom left, you can see the One Health conceptualization, and what we see here that our clusters are kind of geared towards the different dimensions of One Health. So our One Health governance system, of course, is going about the entire structure. How can we create governance systems to promote intersectoral collaborations, to promote working between disciplines? Then the food system is the place where agriculture, environment, animals, and humans meet, and that's why we want to focus on these food systems. And lastly, then the water systems. Water is the connecting element. From agriculture, from animals, from humans, waste always flow into water systems, get recycled, and used again and again. So a lot of health problems are associated, of course, with water pollution. We work in 4 research locations, in Sao Paulo, Brazil, in Accra, Ghana, Ahmedabad, India, and North Rhine-Westphalia, the Ruhr metropolis in Germany. Our consortium consists of our awarding body, which is the University Bonn, where all of our doctoral students will receive their degrees, either from the agricultural faculty, from the mathematical natural science faculty, or from the medical faculty that is situated at the University Hospital Bonn. Our coordinating bodies is CEF, the Center of Development Research, in cooperation with the University of Applied Science Bonn-Rhein-Sieg, specifically the International Center for Sustainable Development, ITSNE, and the UNU EHS, the Institute for Environment and Human Security. Lastly, we have our implementation partners that are situated in the individual research countries. So in Brazil, we have USP, the University of Sao Paulo. In Ghana, we are working together with the University of Ghana and the Institute of Statistical, Social and Economic Research, ISER. And in India, we're working with the Indian Institute of Public Health, Gandhinagar, IIPHG, which is part of the Public Health Foundation of India. And of course, as mentioned before, our funding body, the Ministry of Culture and Science. So what are we actually working on? So initially, we developed cross-cutting themes. Our cross-cutting themes are the connecting elements that connect the different topics together: water, hygiene and public health, healthcare, society, and food security. All of these cross-cutting themes are interacting with the 3 dimensions: human health, agricultural, animal health, and eco-health, ecosystem health, which are the elements of the One Health system. So what do we work on specifically? We work on One Health governance in Accra and Ahmedabad, where it's about how do we operationalize, how do we implement One Health. We're working on the classical topic, antimicrobial and antibiotic resistance, which is the classical One Health topic in Amdebat, in the Ruhr metropolis, specifically in Dortmund, and in Sao Paulo. Then we're also looking at infectious diseases, waterborne and vector-borne diseases, which is a focus in the Accra region in our study. We also have urban agriculture and food systems that are explored in Sao Paulo and in the Ruhr metropolis, specifically the city of Essen is the focus there. And lastly, we also have green and blue infrastructure, which was explored in Amdebat, in the Ruhr metropolis, and also in Sao Paulo. So as you can see from these different research topics, it's a wide spectrum of topics that fall under One Health. And what is also quite clear is that we do not follow simply the classical One Health approach, which focus on zoonotic infectious diseases and antimicrobial resistance, but we actually look beyond these classical approaches to a more extended view of One Health. We want to go beyond the pathogenic focus, so the factors that are causing diseases, and also want to look into the salutogenetic factors, the factors that are actually promoting health. And this is what we see in One Health as a great opportunity, the idea of implementing health in all policies in order to create an environment where people, animals, and of course the ecosystem itself can be healthy and promote health, creating optimal health for all, rather than simply reducing the risk of infections. So how do we do this? So we looked at a set of frameworks that are already existing. One that is very commonly shown is the One Health umbrella from the One Health Sweden group, which essentially shows the different topics and different disciplines that fall under One Health. I personally like this umbrella quite a lot, because on the top we see the range of different disciplines that are involved: ecology, environmental health, public health, veterinary, human medicine, microbiology, health economics. It also shows in those green bars that we're looking at different levels. Now we're looking at the individual health, we're aggregating that to population health, and then we're looking also at the ecosystem health. So we see the different levels that are all embedded in each other. On the bottom in those two spheres, we see the topics. And as I said before, it is following here a much more classical One Health view, where zoonotic infections are really at the heart of One Health. On the other hand side, we see comparative medicine, which is a discipline where we are comparing humans and animals to gain insights, for example, for the treatment of cancer or cardiovascular disease. Another important point that we see here, and that's on the right side on the bottom, environmental hazard exposure to humans and animals. And this is actually where I see the shortcoming in this conceptualization of One Health. Even though this umbrella encompasses quite a lot of topics, what we do see is that the environment here is actually viewed as a place of exposure, as a transmission medium. So rather than actually having a value on its own, it is reduced to being the place of exposure. So we have to go beyond this and see the environment as having a potential of health promotion in its own right. A very classical view of One Health is these three spheres: human health, animals, environmental health, that are simply overlapping. Here we have additionally a cloud of different disciplines and topics that are kind of part of One Health. But what is missing in a framework like this is actually understanding how are these different elements interconnected. What we are interested in is finding out what are those intersecting points. Another example of a One Health framework here goes in a little bit more detail. And we see here human waste, animal health, and how they contribute to the pollution of water, soils, and formats. But again, as I mentioned before, here the environment is seen only as an exposure medium. So the humans and the animals are polluting the environment, and the environment then spreads diseases to humans and animals. A very pathogenic approach. And we want to go beyond this and see the health promoting potential also. To sustainably create optimal health for all, we need to tackle the improvement of the environment and seek basically the co-benefits of environmental protection. So what we have created is our own framework. And here we actually placed urban transformations at the center, because our graduate school is One Health in the context of urban transformations. And we use different systems that are influencing either urban transformations in its own right or are affected by urban transformation processes. So on the top, we can see socioeconomic system, ecological system, political systems that are all being affected or are affecting the urban transformation processes. On the other hand side, we see those urban transformations affecting water systems, health systems, and food systems. So the wash infrastructure, the sewage management, the way we have agriculture, the way we practice agriculture, crop selection, food safety, and so on. In the health system, do we have access to healthcare? Do we have access to medication? Do we have access to insurance? And all of those, again, are affecting our One Health nexus, the interactions between human health, animal, and environmental health. But again, when we came to this conceptualization, even though for us it was quite clear that all of those are somewhat interconnected, it didn't quite help us to understand how those connections are actually flowing and how we can use this to integrate our different research topics. So what we did is actually create cluster frameworks. And even though I introduced earlier that we had those 3 clusters, we actually introduced a 4th one, antimicrobial resistance, because we saw that this one requires an own conceptualization. So in our top left, we see the framework for the antimicrobial resistance cluster. And what we can see is in the reddish color that we have the human side, the clinical setting or the community setting, where we have AMU, antimicrobial use. And of course, those flow, the waste of the human population flows into the water, into the wastewater system. On the left-hand side, we have in the brown color the livestock production, where antibiotics are also used for prophylaxis, for treatment, and in some areas of the world still for growth promotion. And this, of course, is affecting food quality. There might be residues, there might be resistance genes that might be still in the food, in the milk, in the meat products, in the animal products in general. And also it is flowing into the wastewater. On the bottom, we have the soil, the water, the plants. Also in the plants, the use of antimicrobials is quite common. And there's, of course, an interaction that these antimicrobials are then entering the soil, entering the water, and are basically circulating within that system. Overall, what we can see in this framework is that there is interactions of the different user groups of antimicrobials that are flowing into the water system, that are transferred via the food system, and are essentially then affecting the entire system again, just as one of the examples. Similarly, we have made a framework on the right-hand side for the governance, highlighting the different elements of the One Health governance system. On the bottom right side, we see our food system interactions. We have nutrition, where we have soil health, where we have sustainable productions that are interacting with each other. And on the bottom left side, we also have our urban green and urban blue infrastructure, which has effect through ecosystem service provision on animal health, biodiversity, as well as also, of course, human health. But even though we had now these different cluster frameworks, we were still not quite satisfied. So we continued our exploration to find an integrated One Health framework that connects our extended understanding of One Health. What we wanted to find is what lies at the center of these 3 spheres. What is actually at that intersect? What actually is One Health? And what we have come up with is this little diagram here, which looks quite complex at first sight. The first thing that we have done is that we have divided the biophysical environment from the social political environment. We're talking about environmental health in One Health all the time. And very often it is reduced, of course, environment to the biophysical environment, but there's a relationship between the biophysical and the social political. We place the biophysical environment at the center because the biophysical environment is at the heart of health. If we can provide a healthy biophysical environment, clean water, clean air, clean soils, clean plants, then we can also protect our climate, we can protect our environment and create a place where human health and animal health can be optimal, where it can be promoted. That biophysical environment is governed by the socio-political environment, by the governance, by the culture, by the human behavior, which is affecting the way we are interacting with our environment. And those are places where we, from the One Health perspective, can have interventions. The last innovation in a way that we conceptualized in this framework is that we split health beyond physical health. Health is more than the absence of disease. And we know that. The WHO has already told us this in the 40s. And this definition of health is very commonly cited. But in One Health, still, we are mostly reducing health to the physical health. To some respect, we might include the mental health. But what about social health? What about spiritual health? By separating out the different types of health, the different dimensions of health, it becomes much more clear that it is necessary to pursue a salutogenetic approach to One Health. How do we create optimal health rather than just seeking ways to reduce infections, to reduce the burden of disease? If we want to sustainably create health improvements, we need to tackle our biophysical environment, we need to promote a healthy environment in order to ensure that we can have optimal physical, mental, social, and spiritual health, not just in humans, but also in animals. Now I want to pass the word on to Anna Brückner, who is going to explain to you how we now took this idea of this extended One Health view into the urban context. Because here we still noticed, even though we had created this more expanded One Health view, that a crucial component of our graduate school, the urban side, was missing.
Hello, my name is Anna, and I'm going to guide you today through the evolution of a framework for urban One Health studies. So, as Timo has presented already, there is quite a large number of One Health frameworks, but none of these seemed really suitable for our graduate school. So we decided to develop a new framework that would actually be applicable to our graduate school. And we started thinking, what are actually the integration points of our studies? And we came to the conclusion that all of our studies are taking place in the urban context. So urbanity is the characteristic of and the integration point within our graduate school. And as you know, we conducted research in 4 metropolitan areas with, of course, different urbanization dynamics and also different sociocultural city types. So, for example, we have the European city type or the Latin American city type. And of course, all these different areas have different urban challenges or different urban problems. And also the city's vulnerability and the resources to overcome these urban challenges differ between the different areas. But still, the common point is that all of these areas are cities according to the general accepted criteria, size, density, and heterogeneity of the population. So here you can see some impressions of our metropolitan areas. And as I said, we have all the different types of cities. So we have, for example, Sao Paulo as an example of a mega city, which about 22 million inhabitants if you consider the whole metropolitan area. And we have, for example, Accra in Ghana as a medium-sized city of about 2.5 million people. And if you look at the density, this is also quite diverse. So we have, as a forerunner, Ahmedabad with about 9,900 people per square kilometer, and the Ruhr metropolis was about 1,150 people per square kilometer. And as all these quotes show, the cities are characterized by a diverse population. So in terms of ethnic groups, but also of castes or religious categories. So another important thing to keep in mind about cities is that cities are not only complex and diverse, but they are also dynamic. That's also why we have that in our title, Urban Transformation or Transformative. So cities are affected by global development trends such as the climate change or political and social changes, but they are also driving these global development trends, for example, by emissions. And cities are also affected by internal or local driving forces. So as an example, in Ruhr Metropolis, it's very unique about this German area that it is still struggling to overcome the ongoing structural change. And another thing to keep in mind is that research and practice have developed guiding models to promote urban development. For example, based on the concept of sustainability, we have the resilient city or the smart city, but these concepts stay very much normative and they have a limited feasibility. So what does this mean now for One Health in the urban context? So first, the urban characteristics, which I just presented, might increase the pathogenic interactions between humans, animals, and the environment. This is because in cities we have an artificial environmental design, which in most of the cases is at the expense of ecological health. So ecological problems are often externalized to the city hinterlands. In also many cases we have an increasing density, and therefore we have the danger of the emergence or re-emergence of zoonotic diseases, what we also currently all perceive during this pandemic. And therefore, cities have also been identified as pandemic ecosystems. Another fact is that the urban stressors or health risks for humans, animals, and ecosystems accumulate. So examples would be the emissions, but also the light and noise pollution or the city's microclimate. Cities are marked by sharp socioeconomic disparities. So we call them the urban or urban health inequalities. And these inequalities might also turn into urban One Health inequalities. So if we think, for example, about the distribution of environmental health resources and risks and the related disease burdens. So as an example, the risk for the occurrence of zoonotic diseases is much likelier in poor communities with a little provision of safe wash or with little provision of public services. And then urban characteristics can also enable salutogenic interactions between humans, animals, and the environment. So examples here would be the blue and green landscape design, but also that compared to rural areas, cities often provide a safer wash or they have a less pollen count compared to rural areas. For sure, one has to say that humans are the main beneficiaries of this general urban health advantage, which we know and just manifests in terms of better economic resources compared to rural areas or the better provision of healthcare facilities. But as I said before, we need to consider the inner city disparities. So in the end, we came up with another new framework for urban One Health studies. And as you can see in the center, this urban ecosystems, so we consider cities as urban ecosystems. They consist of the physical or natural environment, the sociocultural and economic environment, humans and animals. And the interactions between those different clusters can be categorized, for example, into food supply and nutrition, water security and sanitation, zoonotic and vector-borne diseases, or urban green and blue spaces. And for sure, this urban ecosystem does not stand alone, but it's affected and also affects the global and local driving forces and development trends. So these you can see at the outer circle. And the overall goal would for sure be One Health, which could be translated into urban ecosystem health, which would be the measure of biodiversity, natural features, ecosystem services, pollution and ecological hazards in terms of benefits or impacts to people and nature. As a conclusion, so the One Health nexus is likely to manifest differently within the urban versus the rural context. This is also one conclusion which we have drawn in our research brief, which you could read in the break. A framework for urban One Health studies that explicitly considers urban characteristics might help to guide research, but it seems still insufficient to guide urban policy making. And with that, I want to hand over to my colleague Anna, who's going to introduce you now our framework for policy making. Thanks for your attention.
Hi everyone, my name is Ana Maria Perez, and I will be presenting here the conceptual framework that will aid the operationalization of One Health. This is particularly important for policymakers. And this work was developed by Timo Falkenberg, Juliana Minetto, Krupali Patel, Dennis Smige, Sandulya Sobant, and myself. So first of all, I would like to clarify that by operationalization of One Health, we mean to make this concept measurable and understandable, to be able to address the challenges of the complexity of health issues in the cities. If we look at the needs for operationalizing One Health, we have that the top priorities is a coordination of different institutions, that there has to be some integrated action at different levels of governance, that different sectors have to be oriented with some actions, and that the socioeconomic and cultural context have to be kept inside. So the processes for intersectoral collaborations needs a common understanding of the drivers of disease, the implications of the changes at broader scales, to identify the strategies to tackle those threats, and define clear outcomes. These components we identified by the work that we have carried in the graduate school, and also Timo and Anna earlier today presented other frameworks that have a common component on those four elements. So we were looking at frameworks, and we identified that for our purpose, the framework that I presented here that looks at the driving forces, the pressures, the states, the impacts, and the responses, known as the DIPSER framework, was a very good tool, and it has already been used to look at the environmental health, human health interface. So this is how our framework looks like. And we have that on the top, the driving forces can be coming from global processes and local realities. And like just to summarize this at this point, the action for One Health comes where the umbrella is. So more specifically, on the top, the driving forces, they are rooted on changes at social, economic, political, and ecological spheres. Following, the threats that are derived from the changes and the driving forces. This can be grouped at different spatial scales, specific sectors, and population groups. The room for One Health action is identified here as the strategies, and it includes multiple actors and multiple sectors for which the specific roles have to be identified. Also, the powers of those actors in politics and economics have to be defined. The position of those actors regarding the benefits and problems derives from solving health issues, and the perceptions of those consequences. At the bottom, we have the outcomes, which have to be as inclusive as possible to sustain intersectoral collaborations over time, and also to make sure that all the actors involved can in the long run achieve their institutional goals and priorities. To look at an example of the application of our framework for operationalization, I chose a case of antibacterial resistance. And on the top, we can see that the main driving force is an inappropriate and excessive antibiotic use in animals, plants, and humans. This is being impacted by aging population growth, overcrowding in urban areas, unhealthy lifestyles, intensification of agriculture, and unregulated access to antibiotics. The threats are present at individual levels, but also at bigger scales as healthcare facilities, farms, and the community. And particularly risk groups are elderly, children, farm animals, pets, and wildlife. So the strategy for addressing antibacterial resistance will be the reduction in the use of antibiotics. And this can be implemented by WASH interventions, surveillance on antibiotic-resistant bacteria, and education. And this will have the aim to achieve the reduction of the burden of antibacterial resistance. So as closing remarks, I would like to say that the umbrella framework is very dynamic. It doesn't have to start as a top-bottom framework, but the outcomes can be used to define future transformation processes. And also the outcomes can determine the actors and sectors relevant. Furthermore, the threats, as those are usually the known instances for all, the threats can be identified, and from there, the further elements of the umbrella can be filled in. So finally, I would like to say that intersectoral collaborations, particularly for One Health, and the operationalization in this case, it's an iterative process that needs joint prioritization and consent. Thank you very much.
So, back live. Okay, so once again, a reminder for everybody: use the Q&A if you have any questions. Me and Anna and Anna Maria are now going to address some of the questions that have been posed. And one question that has been up here was how to cope with AMR in the environment. And I think that this was picked up already in the presentation in one of the frameworks that I presented. That of course the transmission of antimicrobial resistant pathogen, but also the antimicrobial residues and antibiotic resistant genes into the environment is a key problem. And it contributes in terms of residues, for example, to the development of new resistant pathogens, not even just pathogens, but also just resistant microbes, which in turn can contribute to passing on their resistance genes to other pathogens also. So how do we cope with it? Well, there is really not a way to cope with antimicrobials in the environment. The only way is to avoid them to actually reach into the environment. So by controlling, for example, the discharge of antimicrobial residues from hospitals, from pharmaceutical companies, to have stronger regulations and some kind of filter mechanisms. At the same time, reducing the use among the human and also the veterinary sector and agricultural sectors can make great contributions. So we shouldn't really think about how do we cope with antimicrobials in the environment, but rather how do we avoid them to actually reach into the environment in the first place. So that was one question that was there. Another one that has been already upvoted about the relation to mental health. And maybe Anna, as you have been working in this regard also, maybe you can share some thoughts on this.
Yeah, so hi. Sorry, I had to unmute it myself. Yeah, thanks for the question. I was actually very happy that someone asked for the mental health part. So when we think about urban green and blue infrastructure, for example, then definitely being exposed to these spaces has some significant mental health effects. So that was also the reason why we support this expanded version of One Health, because we feel in the classical concept, which is like really much about zoonotic diseases, the whole mental health part would like just fall over. So yeah, that's actually a supporting factor for the extended One Health concept.
Okay. Yeah, I think that quite well sums it up in terms of the mental health importance. We have one other study from Jessica Filappi, who actually I think is here today in the audience, who actually explicitly worked toward on mental health and mental restoration in regard to the use of urban parks. Jessica, if you want to join in on this, give me a hands up. If not, it's also fine. Then what she actually explored in her research is the relationship between biodiversity support and mental health. And it's really quite interesting when we're thinking about designing urban green spaces, that very often we focus on individual elements. Like we focus, for example, on the human health side. How do we ensure that there can be a park that promotes physical activity? How can we create a park that is tranquil and helps people to restore their mental health? But all of this is, of course, in a relationship also with the way the biodiversity, for example, works in those parks. So if you imagine we build a park that has a big football pitch where people can play football, where they can run around. Of course, this is not something where birds are going to be very present, because they, of course, don't like this noise level. At the same time, if we build a place where we have very dense forest-like structures in the parks, which are very good for biodiversity, this might create some feeling of unease for some people, because you cannot really see anything. You might have the fear of people hiding in the bushes somewhere, which of course is then going to stop people from being able to relax and then to actually have that mental restoration aspect. So it's kind of finding a balance between how do we create places in terms of urban parks that can promote mental health. So having places for contemplation where you have wide views, where we might also have some blue, some water elements inside. At the same time, being able to promote the biodiversity by having places for refuge for animals, where they can actually breed, where they can be away from humans, and also have places where physical activity is possible. And so we need to create kind of multifunctional parks. And having mental health in that equation is something that, as Anna has said, is something that we view quite important in the terms of the extended One Health view. Yeah. What else do we have here? We have the one question in regards to the climatic differences in our study selection. To be honest, this was not part of our selection criteria in terms of what climatic areas. We were focusing more on having a global spread. So basically placing in Latin America, in Africa, in Asia, and in Europe, to have that global comparison. These climatic factors, this is actually something that comes as a side effect, and is something that needs to be, of course, considered when making comparison between these cities, that there's significant cultural differences. There is differences in terms of the climatic environment. There is differences, as Anna has explained, in terms of the density of the cities and the size of the cities. And all of those need always be considered when you're trying to compare these different metropolitan areas with each other. Do we have any other questions? Now, this question about psychobiotics, I think this is not something that we are quite qualified to answer here. I'm not sure. Anybody wants to respond to that? I don't quite think so. Okay, we have a question here regarding neglected tropical diseases. Someone wants to pick that up?
Perhaps we can open the mic to, like, I don't know, Joshua. That's one of the participants, and he works on that.
Joshua, are you ready? You get the permission to talk.
Yeah, can you hear me?
Yes.
Okay, yeah, perfect. Please, can you, I don't have access to the question. I would like to know what the question is about regarding
The focus on neglected tropical diseases.
Yeah, perfect.
Do you also have neglected tropical diseases in the focus? So it is basically your study. You can just briefly give an insight.
Yes, yes. As part of our study in Ghana, we have schistosomiasis as one of the neglected tropical diseases. And in the case of Ghana, it was considered as the most neglected among the neglected tropical diseases. And we explored the human interactions with polluted water systems, and then how that influenced the exposure and risk factors of the incidence rate of the disease. So there we studied school children and then found their water contact patterns, and then also access to sanitation and hygiene facilities in the area. We also have that as part of the publication, which you can access online. Yeah, thank you.
Right, thanks, Josh, to sum that up. We do, of course, have also this side, and I think this is one of the elements that makes our graduate school quite unique, that we try to capture both sides of One Health. The very classical view that looks at zoonotic diseases, infectious diseases, and of course also neglected tropical diseases. And on the other hand side, we also want to work towards the extended view of One Health. So our mission, in a way, is always to work towards implementation and operationalization of One Health. To contribute to that is mostly in the classical sphere, because this is currently still the dominant way of conceptualizing One Health. And at the same time, we also want to contribute to extending the theoretical basis of an extended One Health view. Do we have any other questions? At the moment, I don't see any. Anna Maria, maybe you can give us a little bit about the operationalization of One Health in terms of the policy framework you showed, and why you think this is useful for actually operationalizing One Health, maybe with your experience from your research from Ghana.
Yes. So, hi everyone again. I work in Ghana, and I am looking at the governance side. And in that sense, I think that the concept for operationalizing One Health was something that after looking at some of the projects we have in the graduate school, we came out with the conclusion that it was important to give, or to at least provide such a tool to the policymakers that we are working with. In Ghana, I noticed that there are a lot of efforts that have been taken, and also a lot of stakeholders are going into that process of engaging other actors and also making them aware of the One Health concept, to try to create a group that can support a One Health policy in the country. So I think that having a hands-on tool that can allow, for example, to put us, or to identify one of the zoonotic diseases or one neglected tropical disease at the center, or as one of the main threats, and then on that identification to find the strategies to find the sectors and the actors that have to be involved to look, to make a bit of an abstraction, and also look at which are the causes of that threat at the beginning. We have talked a lot about the environmental concerns here, and I think that is going to be one of the spaces to look at it from another view, is taking the One Health beyond the zoonotic diseases and the human and animal health, and also to identify the outcomes and the goals that want to be achieved. I think it's very important just to have that clarity. Doing some literature review and looking why some health policies have not worked in many countries. That was one of the main concerns, that when policies are being developed, there is not this evaluation to try to break down who is going to be responsible of what and which are going to be the actors involved. So I think that this is what we wanted to provide with these concepts, and I hope that some people around will be looking at our framework. We are hoping to publish it as a policy brief. So once it's out, we will let you know, and then you can also take it as a tool for implementation. Thank you.
Yeah, great that you pointed that out. We're currently in the process of publishing this framework in the urban health policy brief of the Chinese Academy, where we actually went last year, just before this COVID outbreak, actually, to attend a conference on urban health.
Thibaut?
Do we have any other?
Yes. I would quickly like to just mention our other paper on the coronaviruses, because that is
yes, go ahead.
In that paper, it was published about a month ago, I think, by the One Health journal. We can perhaps in the break we can just put the link to the paper, because there it's important that we identify the One Health actions. For people wondering what is a One Health action, I think that there we did a good job looking at the big three coronaviruses that we know now, like SARS, MERS, and COVID-19, and we were searching for literature that are actually mentioning some actions and the sectors involved in One Health. So I think that will be a very good complementary publication to the people trying to fill in the umbrella. Yes.
Yeah, very, very good remark. So we will share these publications also on our website. You will find a publication list, and actually on the CEF website, this is already available. But we will link it also to this symposium for easy access for everybody who is interested to find out more about some of the publications that have already come out of the graduate school, and also keep up with further publications that are coming out. What we do already have on the website currently is the policy briefs and the research briefs that you can find on the symposium website. But before we get to the time where you can read that, I think I would move ahead to our country cases, so thanks Anna and Anna Maria for addressing the questions. And we would now, I guess, move ahead to the country case presentation.
Thank you very much, and welcome once again to our One Health Symposium. And it's about our One Health and Urban Transformation project, where we are identifying risk, developing sustainable solutions to health. Today we are sharing with you our ideas from our projects in Ghana, focusing on One Health governance and health issues. It all started with the formulation of One Health policy. And how did it happen? There have been coordinated and multi-sectoral initiatives in Ghana to prevent diseases through the support of donor organizations in the past years. And in 2017, a One Health technical working group was formed to develop a national policy for Ghana. And the focus of the One Health policy was on infectious diseases, with particular focus on zoonosis. For example, 6 zoonotic diseases were prioritized, and they are avian influenza, rabies, hemorrhagic fevers, bovine tuberculosis, and trypanosomosis. Anthrax was the other disease. It was found out that cooperation among institutions has been reported as a major challenge hindering the implementation of the One Health policy. Today, the question we have today is how to translate the One Health policy into action and how to extend the One Health understanding in Ghana. And further, focusing on the expansion of the One Health understanding, then we need to acknowledge that much effort has been done in terms of the animal health, human health, but the environmental component of it has not been well captured in the framework. And in order to do this, there is the need for us to integrate the environmental component of health into the One Health policy. This can be done through land use planning, improved waste management systems, and the protection of surface water bodies. This is because environment is a component that actually influence the emergence of diseases, either related to human or the animals. And in terms of environmental health, infectious diseases are very important. So there is the need to also include infectious diseases in the One Health governance policy in Ghana. Focusing on environment, it is important to acknowledge that the interactions between humans and animals within the environment is very complex, and these complexities are some of the issues that needs to be accurately tackled. Infectious diseases is one of the health challenges that we face today. And it was identified that these infectious diseases are linked to the environment, and the environmental health, also improving environmental health, is a strategy to tackle these infectious diseases. We had case studies of infectious diseases in Ghana, focusing on waterborne diseases and vector-borne diseases. And these diseases, again, were linked to the humans as well as the environment. And here we're talking about the biophysical environment and then the social environment, where human behavior plays an important role. In these pictures, we can see that the sections of the Odo River is highly polluted, and then also beside is also where we have the cattle raising area just along the river. These interactions between humans and environment exposes them to infectious diseases. For example, we're looking at the vector-borne disease as well as the waterborne diseases. Our study in Ghana, focusing on the human interactions with vector-borne diseases, identified that the incidence rate of malaria is still a huge health challenge in the Greater Accra metropolitan area. And this is linked to the interactions among different categories of factors, and again, which is about the physical environment and then the social environment, where we have the human behavior as well as the health-seeking behaviors. It was also found that one of the risk factors were the open ponds and pits that are existing in the area, which serve as breeding sites of mosquitoes in the area. Whilst compliance with malaria drug prescriptions and the adoption of preventive measures was also a problem in the area, because it was found that more than half of the people who actually receive the insecticide-treated nets actually do not use them. And this, again, has to link with the behavior of the people, looking at the social cultural factors influencing the usage of these bird nets. In order to tackle this problem of malaria incidence, there is the need to focus on reducing the density of mosquito vectors through regular drainage of breeding sites, as well as the use of larvicide to reduce the density of mosquitoes in the area. Our second case study, looking at the human interactions with surface water systems, identified that schistosomiasis is a huge health challenge among some school children in the peri-urban areas in Accra. And the risk and exposure factors were linked to limited access to safe drinking water and improved sanitation, increasing human-animal interactions through sharing of a common drinking water source, where humans and animals drink from the same unimproved sources of water from the river and then from the pond. This creates interactions where diseases can be transferred. Recreational activities, domestic and occupational water contact activities were identified as some of the exposure factors that exposes humans to the contaminated water body as well as the infested snail host. In order to tackle this disease, there is the need to provide wash for both humans and animals whilst discouraging open defecation. Collaborated and coordinated action campaigns for good health-seeking behaviors are required in order to reduce the exposure of humans and animals to the contaminated water bodies, and then also to break the transmission cycle of schistosomiasis, because it starts with humans, where humans get into contact with polluted water. This could be done through coordination of actions and also sensitization of the people, telling them the risk factors involved and also how to adapt health-seeking behaviors. Generally, it could be emphasized that integration of the environmental health component into the One Health policy in Ghana is crucial to tackling health problems, because whilst focusing on the environment, we can reduce the infectious diseases whilst having a trickle down or a positive return on promoting human health and then animal health, because the environment, including the physical and then the social environment, plays major roles in the disease emergence and transmission. So there's the need to integrate this integrate the environmental component into the One Health policy, focusing on promoting the environment and also implementation of land use plans, improved waste management systems, and then protecting surface water systems in the area. This together will improve the environmental health quality as well as the human health and then animal health. How can this be achieved? We need collaborated and coordinated actions that need to be implemented, need coordination, support, and also collaboration and support from the various sectors and various organizations in Ghana in order to bring this policy into action. Whilst we have talked about zoonotic diseases, looking at how One Health policy was formed in Ghana, we noticed that Ghana has advanced with the formulation of the One Health policy. Of course, it has not been implemented yet, but then it is important at the moment to zoom into some synergies between Ghana and India on the policy formulation and control of zoonotic diseases, because this will help the two countries to learn from each other on formulation of the policy and how to transform the policy into action. Yeah, thank you.
Good afternoon all. After an understanding of One Health in Ghana, now it's time to travel to India. As we know, India is not only the second largest populous country followed by China, but also the second largest country with the highest livestock followed by Brazil. So with an increasing complex interlinkages at the interface of humans and animals in the recent past, India has seen many outbreaks of emerging and re-emerging zoonotic diseases. Although the risk factors precipitating the occurrence of emerging zoonotic diseases are many, this side map indicates the likely zoonotic hotspots across the country. So India is one of the prime country to contributing to the global burden of zoonosis. Combating this burden of zoonotic diseases brings the momentum of One Health in India. So far, the zoonosis are being tackled by different ministries at the central level, such as you can see the human component is regulated by the National Center for Disease Control, which is under the Ministry of Health and Family Welfare. However, the zoonosis among the domestic or specifically the livestock animals are addressed by the Ministry of Fisheries and Animal Husbandry and Dairying, which is a newly formed from the department of the same name under the Ministry of Agriculture and Farmers Welfare in 2019. However, the Wildlife Institute under Ministry of Environment, Forest and Climate Change focuses only on wildlife zoonosis, and this all indicates a fragmented approach in zoonosis prevention. Here I want to give an overview of the major One Health movement so far in India. Almost in a decade back, it started with in 2009 that India became with the One Health network of South Asia, followed by the in-country collaboration between the Center for Disease Control with the US and NCDC of India. And there was like 3 years after, the India launched the new One Health Center and the One Health course in the specific to some states, and followed by the One Health concept introduced in the veterinary curriculum. And recently 3 years back, India's National Action Plan on Antimicrobial Resistance incorporated to the One Health approach, and finally in the 2019 the One Health Declaration was initiated by the Ministry of Science and Technology, and by 2020 recently they proposed the National Institutional Platform for One Health with a specific budget. As we know, this One Health implementation relies on collaboration across the diverse sectors. It not only requires the intersectoral but also multisectoral and transdisciplinary collaborations and actions. However, there is a lack of understanding on the required level of integration, and the below figure indicates about the stages of integration, indicating the major actions such as sharing of information across the sector to work as a formal team with mutual planning and the sharing of the staffs. Considering this intersectoral collaboration, India's effort and focus so far remained as solution-based approach, that is either the disease-specific collaborative efforts where both the humans and animals health system actors to collaborate for a specific purpose, for example, National Rabies Control Program that was launched in 2013. And second could be the contingency plan of avian influenza, which was introduced with a key focus on surveillance, clinical management, public health measures in both human and animal health sectors. Even there are few states such as Tamil Nadu in the south, Sikkim in the northeast so far implemented this One Health approach for the rabies control with a collaborative actions between the various sectors. So the key learning from these types of solution based collaboration is having specific targets and aims for the implementation of such collaborative actions. Thus, it should be the one of the key aspects during One Health operationalization, not only in India but also across the globe. In one of our research, we explored the One Health operationalization process with a 5-step approach, as the first step is should be the prioritizing the goals, either it is for the disease control or for the risk mitigation, which remained an utmost important step of operationalization process with the One Health concept. In the context of India, there are few such prioritization activities have been documented in the past. Although the purpose of prioritization were different, rabies, the dog mediated, remained the key prioritized zoonotic diseases in India, which provides a potential way forward to implement the One Health strategies in the country. With a kind note, the challenges for implementing the One Health strategies among others is an acute shortage of animal health workforce both at the clinical and at the community level over the decades. On contrast to this challenge, there are rich presence of the community actors from the human health sector, such as let us say accredited social health activist, a female activist who belongs to the same community and responsible for delivery of various health services, and on an average of 1000 population there is one ASA. So, in addition to it, there is a preference to the top down directives, that means mostly they follow the rules and regulations, and there is low interest for the collaborative activities without a specific goal, as identified in our one-off research. Moving beyond from the issues of zoonosis, where India requires a stringent One Health action to tackle the overgrowing burden of antimicrobial resistance, India recorded a strategic of 12.9 billion units of antibiotic consumption, which was the highest among all the countries and India is one of the with highest bacterial burden in the world. And as we know, there are many large populations suffers from chronic diseases and about 40% children are malnourished, resulting into the risk of infection to be the high, and it's a challenge for overgrowing it for the decades. The reasons leading to such situations are multiple. It might be start from the easy access to the medicines over the counter in medical stores or self-medications, and there are varying approach to the treating doctors, and empirical but incorrect use of antibiotics is also existing, and simultaneous use of more than a single antibiotics when actually not necessary. That might be also a potential reason. The lack of strict implementation of policies such as the Schedule H1 drug, the policy rules regulation containing to it, and there are also control by the regulatory authorities is found to be the poor. And unethical commercial practices to promote the sale of antibiotics in large quantities also evidenced in this country, and use of antibiotics by other non-medical and informal healthcare providers also documented in some parts of the country. In addition to this, there are some silent explainer of AMR at the interface of human and animal. As per the India's mythology, the cows, which is the most common livestock, considered as a sacred symbol of life. Usually people worship them. The intimate relation between the human and animals, especially the livestock, considered them as a part of their family. So which results into the closer interaction between the humans and animals. Further, the poor hygiene practices and the lack of awareness multifolds this issue. In addressing these issues, however, the Indian Council of Medical Research launched this AMR surveillance initiated to enable the compilation of data on 6 pathogenic groups from the 16 regional laboratories. This led to the implement of the National Action Plan on AMR in 2017. However, the feasibility of community-based surveillance is yet to be explored in many contexts. So from this journey, our key recommendations lies broadly in 2 categories. One, for strengthening the governance, and second, for the disease prevention and control with the vision of One Health policy making in the country. So for strengthening the One Health governance, we propose that for enhancing collaborative efforts, there must be the inclusion of private actors should happen, and the vertical collaboration should sustain even after the health emergencies. For strengthening the local health systems, we propose the One Health platform for the knowledge sharing and a integrated One Health training module, not only focusing the zoonosis and AMR, but also on the leadership qualities of all the health actors. For disease prevention and control, one of the key factor of recommendation is that for improving the knowledge, the ASAs who are at the reach at the community level from the human health sector, the training on the zoonosis and the AMR awareness should be conducted. Health promotion on hygiene and disease control should be enhanced in the field level. And definitely for early detection of risk, there should be the joint resource sharing between the human and animal health sectors. There must be some strategies for cross referral of cases between the physicians and the veterinarians to be established in this context. The strengthening of AMR surveillance, extending beyond the laboratory based to the community based, and lastly but not the least, that we can promote these ASAs who are reached at the community level as a One Health activist at the community level. So while India has advanced in the human and animal health collaborative activities, it will be great to zoom into understanding the wider applications of One Health from Germany. Thank you very much.
Thank you very much, Jasuband, for giving this introduction into the policy recommendations for the Indian context. I'm inviting you now all to pack antimicrobial resistance into your bag and follow me all the way from India to Germany. My name is Dennis, and I'm going to present the policy recommendations for the Ruhr Metropolis in Germany on behalf of our group, consisting of Anna Brückner, Juliana Minetto-Gellert-Paris, Philipp Svoboda, and myself. So as I said, antimicrobial resistance is a global problem. The key driver of antibiotic resistance, which is a subset of antimicrobial resistance dealing with bacteria, has been identified as inadequate and excessive use of antimicrobials or antibiotics in humans, animals, and the environment. On the bottom left, you can see a figure that shows the change of antibiotic use defined as defined daily doses per 1,000 inhabitants per day between 2000 and 2015. What we see is a stark increase for upper middle income countries as well as lower and lower middle income countries. What we also see is that high income countries remain more or less stable, however still at the highest level. Globally, this is how it is distributed. So you can see in the map blue areas that indicate a decrease in antimicrobial use, and you see red areas that indicate an increase. You also see a lot of blank countries where we don't have any data. May I draw your attention to the bar chart below? What you do see here on the left-hand side, which indicates high antibiotic use, a lot of dark blue bars, which indicate high-income countries. Towards the lower end, indicating lower use, you see a lot of low and lower middle-income countries. Germany is positioned in the lower half here. Let's zoom in a little bit. In 2019, there was a study that estimated the burden of antimicrobial resistance on Europe. They estimated that there were roughly 670,000 infections with resistant bacteria. Of those, roughly 64% were associated with healthcare settings. Of those, there were more than 33,000 deaths attributed, estimately, to antimicrobial resistance in 2015. This was back then quite a high number, which was surprising. On a regional scale, this is how it looks like. You can roughly identify a north-south gradient, with northern countries being usually a little better off than southern countries in Europe. Germany, here positioned geographically at the center, ranks in the lower third in terms of antimicrobial use. And in the figure, you can see the antimicrobial use in the primary care sector. In terms of antimicrobial resistance, there are promising developments. Let's look at Germany. If you look at the resistance isolates, or the percentage of it, for methicillin-resistant Staphylococcus aureus, which is a bacteria that is responsible for many nosocomial infections, so infections that you acquire in a healthcare setting, we actually see, starting in 2000, numbers around a little above 10% that started to increase, but also actually started to decrease, ending in 2019 at a lower level than it started in 2000. However, we also see concerning trends. If you look at gram-negative bacteria, for example, here we have Escherichia coli, which is a commensal gut bacterium, and it's resistant to third-generation cephalosporins, which can be roughly considered the second line of treatment against such bacteria. We see that the map gets a little more yellow and a little more orange. Germany is again positioned somewhat in the middle here, but we see that between 2000 and 2019, the percentage of resistant isolates increased up to 10% roughly in 2019. If we zoom in further, let's go to Germany now. Here I want to highlight 2 points, the human and the veterinary medical sectors. In human medicine, AMR tends to be constantly lower at lower levels compared to other countries. AMR here refers to antibiotic use, for example, or what we also saw earlier, the resistance level of certain bacterial species. However, we have distinct geographical differences. If you look at this figure, taken from the very last report on antimicrobial use in human and veterinary medicine in Germany, unfortunately from 2015, we see 16 federal states. North Rhine-Westphalia, the one where we are located in right now, ranks in 2014 the highest in terms of antimicrobial use. In the veterinary medical sector, we see a decreasing tendency in antibiotic use. In 2011, the monitoring started with roughly 1,700 tons used. In 2019, those numbers are down to roughly 670 tons, a huge decrease. However, we also see regional differences across Germany. If you look at the map, you will see a lot of yellow areas that indicate lower than 5 tons of antibiotic use. However, you also see different shades of orange, which indicate higher use. Here, you can see our study area, the Ruhr metropolis, covering parts of orange areas. Why do I tell you all of that? Well, because antimicrobial resistance is how One Health is currently mainly operationalized in the German system. Over the past years, the added value of One Health has also been increasingly recognized in Germany. Take, for example, the World Health Summit that just concluded yesterday. The State Secretary of the Federal Ministry for Economic Cooperation and Development highlighted that One Health will be one of their main pillars for the upcoming years in terms of international cooperation. But also the Federal Ministry of Health established a department on One Health, focusing on antimicrobial resistance. So the One Health approach in Germany is mainly institutionalized and operationalized at the federal level in the context of zoonotic diseases and antimicrobial resistance. You can see here, for example, on the top left, the DART 2020, which is our German antimicrobial resistance strategy. You can also see a memorandum of understanding between several ministries in terms of research on One Health. And you see the German One Health initiatives with its partnering institutions that are all out at the federal level. One Health has also been taken up by the academic sector. For example, our very own research school that we represent today here, One Health and Urban Transformation, is a very prime example of that. But also other joint health research institutions. And we should not forget that in 2018, the University of Bonn organized a big conference on One Health and food safety. However, many regulations and policies that protect and promote the health of humans, animals, and environment are still widely kept separate. This brings me to my first policy recommendation, not to my, but to our recommendation actually, for the rural metropolis. So One Health is mainly institutionalized at the federal level. Regulations and policies are kept separate. So we argue that it makes sense at the local level to start by setting up a One Health committee. You can set it up either at the municipal or the regional level. And its task would be to enable and foster intersectoral coordination and collaboration among relevant stakeholders. Because if you want to bring together stakeholders on humans, animals, and environmental health, this is quite a large number, and someone needs to coordinate that. But let's talk a little bit more on the rural metropolis. A little fact refresher here. The rural metropolis is an urban polycentric agglomeration in the western part of Germany, and it hosts approximately 5 million inhabitants. Due to its past, it's right now concerned with major urban transformations that are ongoing. Ongoing changes include, for example, the co-presence of urban shrinkage and urban growth, the increasing social polarization and segregation, the aging of a highly diverse population and the rising prevalence of non-communicable diseases, and the loss of fertile soils, as you can see in a graph on your right-hand side. This is taken from a study in 2013 and highlights that agricultural areas or soils are lost when with this all associated ecosystem services as well. So let's come to the remaining parts of our policy recommendations for the rural metropolis in Germany. So the local processes I just highlighted, in addition to other global processes such as climate change and with it, for example, extreme weather events, they result in an alteration of critical intersections between humans, animals, and the environment. For Germany, the rural metropolis in particular, we therefore envision One Health to be more than the classical version of it. There's more to One Health than zoonotic diseases and antimicrobial resistance. And for this, we need 2 points. First of all, One Health in all policies. This is very similar to the World Health Organization's initiative, Health in All Policies. What we mean by it is that the nexus of human, animal, environmental health needs to be integrated in the One Health concept in all policies, and not just those that are obviously linked to health. Secondly, it's important to not just consider pathogenic, so dangerous to health intersections, but also health enabling, so salutogenic intersections. In the following, I'm going to present to you 2 examples of what we mean by that. The first example would be the food system. The food system itself is a very complex system that requires holistic solutions. In the rural metropolis, we see a shift in dietary and production patterns. Dietary patterns, for example, have transformed more towards animal-based, highly processed, and energy-dense foods, associated with a lot of non-communicable diseases that we see. Production patterns in the rural metropolis are mainly dominated by large farms that practice intensive agriculture that aim for maximizing the output per area. You could apply an integrated view here. Let's take, for example, human health, animal welfare, and agricultural sustainability. You could argue that human health is mediated by animal welfare and agricultural sustainability. So improving animal welfare, for example, or working on agricultural sustainability might also actually improve human health. What we also argue is that One Health approach can be adopted throughout the entire food supply chain. You could start by intervening at the one or the other stage, like the consumption stage or the production stage, but you can also do it jointly. The second point, moving away now from the food systems, would be One Health as health promotion. So the role of the environment, and particularly healthy environments, whatever you want to define it with, on health of humans and animals is well established. In this context, for example, urban regeneration for urban green and urban blue play a major role and a very critical one. You could, for example, improve the health of humans, especially the mental health, by revitalization of brown areas, for example. This brings me to policy recommendations 2 and 3. So the consideration of both salutogenic and pathogenic intersections. Start small, start local. Develop and implement local One Health interventions. This could be, for example, a multifunctional green and blue space linked to urban agriculture and community gardening. And at the same time, you might even be able to also reduce flood risk. Or you could set up an integrated wastewater surveillance system. This is highly debated now in the context of SARS-CoV-2 and the COVID-19 pandemic. But before that, antimicrobial resistance was a prime example for wastewater surveillance, because by using an environmental compartment, you could monitor what is actually circulating in the domain of animals and humans. Thereby, you should still consider path dependencies and the need for holistic solutions. This brings me back to our example from the food system. You could, for example, promote healthier diets at the consumption stage. You could also argue for clear subsidy schemes that promote animal welfare and soil health, for example, at the production stage. But you can also do it jointly. Policy recommendations 4 and 5. The integration of One Health concept in all policy fields. At a certain point, it makes sense to start integrating the One Health interventions that you started to do at the local level into an overarching One Health strategy. This process can be ideally led by the One Health committee that was set up in the first place. And lastly, you could establish a One Health monitoring system in the area. The task would be to analyze or gather and analyze data, but also disseminate information to relevant stakeholders and conduct integrated assessments of challenges, needs, and impacts in terms of what is going on in regard to One Health in your area and where you need to adjust. Based on this One Health monitoring, you can adjust your system, for example. You could try to set up new research projects or to start new interventions. In summary, One Health is so far mainly institutionalized and operationalized in Germany in the context of zoonotic diseases and antimicrobial resistance at the federal level, as I explained earlier. However, we think that the rural metropolis context provides a unique opportunity to move beyond the classical One Health approach towards an extended version of it. Remember the examples of One Health for health promotion and the food system. To just briefly summarize our policy recommendations. First, setting up a One Health committee at a lower level. Development and implementation of local One Health interventions, thereby considering path dependencies and the need for holistic solutions. The third point I did not touch too much on in my presentation. It's still part of our policy brief. The development of innovative funding models. You could cooperate with health insurances in terms of health promotion that is linked, for example, to urban green and urban blue spaces. Fourth, integration of One Health interventions to an overarching One Health strategy for the area. And fifth, and not lastly, establishment of a local One Health monitoring. With that, I would like to thank you very much for your attention. We look forward to your comments and questions at the end of this presentation. And I'm now inviting you to follow me all the way from Essen or the airport in Düsseldorf to Sao Paulo, where we will hear more on the extended version of One Health. Thank you very much.
Thank you. So now in representation of the students working in Brazil, I will present the extended approach of One Health. So given the tumultuous political situation in Brazil, the impact of the pandemic, and the state-level message of economy over health and environment, there has been little advance in One Health policy and One Health action. Through an exploratory analysis of the One Health status quo in Brazil, evidence suggests that there has been some actions related to the One Health in the last years. The focus of One Health has been on zoonotic diseases, and the One Health actions also working on transversal topics such as zoonosis hotspots and One Health training. The One Health actions have been focused on education and knowledge management, surveillance, identification, and control of disease. Examples of this education and knowledge management are, for example, the One Health Summer School held last year, and a series of trainings and congresses and symposium that were developed during this year, especially in the context of the COVID-19 pandemic. An interesting example of actions taken at the state level is the work done by the Paraná state to promote One Health multi-sectoral collaboration. We identified 4 kinds of policy instruments that are already put in place. working with topics related to One Health, regulatory, economic, and fiscal agreement based in information and communications. Examples of them are, for example, the National Surveillance Systems Agent's resolution to manage waste disposal of veterinary drugs. Also, there is a discussion paper on Our Planet, Our Health, Our Future, launched at the Rio+20 United Nations Convention. And as actors, we've identified a diverse set of actors, mainly the state agencies such as the Ministry of Health, the Ministry of Agriculture, and universities and research centers, and also an interesting public-private partnerships at the municipal level dealing with animal health. In terms of the knowledge management, there are institutions already working to advance One Health in the country, such as the One Health Commission and the One Health Platform, and also the World Organization of Animal Health. There is also an interesting cooperation between the Institute Pasteur and the University of São Paulo, and they are developing research on emerging pathogens and methods to prevent epidemics of infectious diseases such as Zika, dengue, and yellow fever. Although we observe some engagement trying to bring the One Health concept to multiple sectors of the Brazilian government, initiatives stayed at the academic and the extension level. Brazil still lacks a target-oriented and multi-collaborative One Health policy to be applied at the multiple Brazilian context. Having said this, we cannot ignore the elephant in the room and thinking about the environmental component and its neglected role. For the case of Brazil, we focus, and specifically for the city of São Paulo, we focus on the multiple benefits that urban agriculture provides, and also the green spaces benefits for mental health and wildlife support. Urban green infrastructure in the form of parks, street trees, and gardens improves environmental quality within the city and also provides many services such as pollutant filtration, microclimate regulation, noise buffering, stormwater regulation, and biodiversity support. Through the provision of this improved environmental quality, opportunities for improvements on the physical health of humans come together, but also the promotion of the social interaction, the stress reduction, and the association of lower levels of adverse health outcomes such as cardiovascular and respiratory diseases. In the case of São Paulo City has a lot of green cover. Almost 20% of the municipality is covered by green spaces, but the distribution is unequal. Most of it is located in the south and in the north, and in the rest of the city, the distribution is insufficient and unequal. Furthermore, the quality of the green spaces affects the potential benefits they can provide to visitors. For instance, the potential for mental restoration varies amongst parks, following the perceptions of environmental quality and maintenance. Green space quality is also reflected in the capacity to support a diversity of wild fauna, which might potentially also boost human health benefits and other ecosystems provided. In this sense, my colleague Jessica Felapi, part of the graduate school, developed this framework based on the One Health approach, identifying the urban environmental health, the human health, and the animal health, and the interactions associated among the three components. She tries to depict in this framework the interlinkages between the green space quality, the mental health, and the wildlife support, identifying the relationships at the local fine scale, in this sense parks, but there can be other green infrastructures, and the adjacent landscape. In the environmental dimension, we see that the landscape attributes and the spatial configuration, the vegetation structure, and the design and management of the parks have an association with the human health in terms of the degree of the restorative experience they provide, but also on the wildlife they support. Following this discourse, I would like to talk about urban agriculture in the city as a benefit multiplier. Well, multifunctional agriculture performs several ecosystem services and functions and interacts with several socioeconomic and health factors, creating various benefits to the communities while also promoting biodiversity and safeguarding the ecosystem services. Using this very comprehensive conceptual framework from Soulas and colleagues, we are identified the functions that urban agriculture performs in the city. We are focusing on urban agriculture, on home gardens, and enclosed countryside, which is more related Also, there is empirical evidence provided that these spaces provide habitat and several socioeconomic and health factors, creating various benefits to the communities while also promoting biodiversity and safeguarding the ecosystem services. Using this very comprehensive conceptual framework from Soulas and colleagues, we are identified the functions that urban agriculture performs in the city. We're focusing on urban agriculture, on home gardens, and enclosed countryside, which is more related to the urban-rural areas in the periphery. So, these three types of urban green infrastructure perform the food provision, which is the one we are investigating in this graduate school, but empirical evidence provides information about the role that urban agriculture plays in other ecosystem services. For example, the air quality, the soil and nutrient cycling, the aesthetic and spiritual value of these infrastructures. In terms of the ecosystem health, we are analyzing the vulnerability and the adaptation of the green infrastructure to the shock of the drivers that we spoke today before. But also there is empirical evidence provided that these spaces provide habitat and species support, energy and materials cycling, and also water quality. They improve the water quality. In terms of the socioeconomic health, we are taking a look at the income and education, at the employment, at the access to housing services, and also at the lifestyle decisions of the communities and of those people engaged in urban agriculture. In terms of the community health, we're investigating the social capital, but we also recognize that urban agriculture has a potential to improve the community empowerment and identity. And in terms of the physical health and psychological health, urban agriculture has direct impacts on cardiovascular diseases, positive impacts, but also in the restoration and the stress reliever, and also on the positive thoughts of those engaged into urban agriculture. So this is just an example of how multifunctional agriculture is and how we need to conceive it when implementing it, and conceive all the factors of health that urban agriculture and urban green can bring to the urban ecosystem. We took a look at the policies put in place dealing with urban green and health in the city of São Paulo, and we found three very powerful instruments: the strategic master plan, the family health strategy, and the plan of food and nutritional security. So these policy instruments are already acknowledging green infrastructure and its multifunctionality, but there is still the need to adopt a holistic approach and also to identify the new roles that urban green adopts across sectors. In Sao Paulo City, these instruments already integrate the factors of health and green, but we still observe a weak collaboration among sectors. A very interesting example is this program, the Green and Healthy Environments Program. It's a program where the Ministry of Health and the Ministry of Environment join forces together to develop interventions at highly social vulnerable communities, where they identified their concerns, their environmental concerns, and they also started to provide basic health services. After the analysis of these concerns, they implemented interventions focused on biodiversity and waste management, and it's a good program that is already put in place, but we still observe that there is no explicit assessment or monitoring of health outcomes, and there is a limited cooperation among sectors. The main health drivers addressed into all these instruments are the nutrition, the food security, the physical and mental health, the zoonotic diseases, and the ecosystem health. So after this exploratory analysis, we identified some entry points to start building One Health approach or municipal policy from the bottom up. And the first one is that we agreed that the multi-stakeholder collaboration between the Municipal Council of Food Security and Nutrition should continue, but they should seek for a stronger link to the public health. Urban agriculture and urban green should explicitly be integrated into urban planning, public health, climate change mitigation, and adaptation policies. When designing parks, the targets of availability, accessibility, and quality should be taken into account. And also, there should be priority areas to implement green infrastructure, considering an equal distribution across the territory of the city. We also believe that the integration of multifunctional green infrastructure into new urban development should be done. And also, there is the need to assess the current urban green, identifying the roles they adopt across the three components of One Health. And finally, well, the One Health approach might contribute to practical guidance on more effective green space design and management to maximize socio-ecological benefits. Thank you. If you wish to contact my colleague that is not here, Jessica Felapis, she's working with the urban green spaces, and myself, I'm working with urban agriculture. Thank you.
So let's take a little bit of a breather. I know it's a lot to take in. It's quite a few studies that are embedded in these country cases, take a moment to put your questions into the Q&A. First of all, I would like to point to one question that was asked regarding the role of human, animal, and environmental health in the context of One Health. So essentially what Manuel Glass is asking is, the question is arising on how we should understand the One Health concept in vector-borne zoonotic disease control. Is it really about equally improving the health of humans, animals, and the environment? And is it even possible? I have often the impression that ultimately health, public health counts. I think this is a quite good question. And so with that, I would like to open this discussion. Maybe Jasubant, you have already addressed this in written form. Maybe you want to share this also live, your ideas on this.
Yeah, thank you, Dr. I really appreciate the questions because we are also debating the same thing for last 3.5. Really, One Health really weighs or give the equal weights to all the dimensions. So the answer is not straightforward, say to yes or no, because when we say, like I should quote the recommendations from Professor Jacob, that he said that you go for the intervention in the animal sector or environmental sector, for example, in the animal vaccination, that has a good impact on human health. So ultimately, One Health, it's now it's anthropocentric, but of course, that should be the human health to be on the top domain of any interventions that we do at animal sector or at environmental sectors. So I feel the giving the weightage is difficult, but of course, the focus need to be on the human health and after all, the sustainable development. Yeah, thank you.
Yeah, thank you, Yash, for pointing this out. This is just as he just said, something that we have been discussing quite a lot, and I think this is a very important issue in the context of One Health research right now. And this kind of leads me to the follow-up question by Christoph Höser from the GeoHealth Center. Who said that he has the impression that this intersection of the different health aspects that are part of this One Health nexus always go into one direction. No, basically everything leads to the human health outcome. And the question is there then, related to this from him again, maybe it is also time for us in One Health to start thinking the other way around, outcomes for veterinary and environment as a result of human health. Any of the speakers wanting to take this one? Otherwise, I'll start myself. And must say, like, Christoph, you really hit the nail on the head there. It's very clear that mostly in One Health, the focus is on the health outcomes for humans. And in a way, this is also, of course, quite natural, because, of course, the human health is what policymakers, what governments, what they care about, and also what donors care about. And that's why the monetary flow is, of course, into the protection of human health. When we look into this opposite view, I personally think it is very important. And as you quite rightly pointed out, it has also some implications in regard to the COVID-19 aspects itself. Because if we start to see how our human health, and in this current pandemic, for example, how is our current pandemic affecting, for example, the environment? Is there some positive aspects? Is there some negative aspects? And both are true to some respect. We are maybe flying less, but now we have masks that are polluting our environment. So there is a very interesting One Health question, in my opinion, that can be posed from the other way around. How is human health affecting the environment? And there, in terms of antimicrobial resistance, I see a very clear link in terms of, let's say, production of medicines, not just antimicrobials, but medicines in general. There are certain wastewaters that are produced, and these can end up in the environment. We also know about the situation of the anti-pregnancy pill and how this affects fish populations in terms of having multi-gendered fish because of the estrogen that's in those pills. So there's certainly questions that can be posed from the other way around, and actually looking at what impact do humans, in terms of human health, both positively and maybe also negatively, have on the environment and also on the veterinary sector. In the end, I would say that human behavior, I mean, this it's the deciding factor. The way we are behaving, the way we are acting is creating problems for the environment. And this is, I guess, where I would say we usually in One Health, we would always take it one step further, and in the end, it comes back to the humans. And now, why is human health always the outcome? Because in the end of the day, I feel everything comes back to the humans. So if we take this example of the environment, for example, how does human health affect environmental health? How does human behavior affect environmental health? this health status of the environment is going to have feedbacks on the human health again. So even if we now twist it around and start, let's say, with human health as the starting point, in my opinion, if we take it far enough, the loop will come back, and we will not actually have a linear causal chain, but we will have a kind of circle where we actually see that the individual aspects are affecting each other. I hope that kind of addresses your question, Christoph. Someone has something to add on this one.
Yes, just me, just following on the environmental multifunctionality. I guess it is very important to acknowledge this theory coming from ecology about the multifunctionality of the species and identify the synergies and trade-offs we bring among the three components to maximize the health, the 100% health in all the three components, I guess. So I guess now it's time to go back to those basic theories and yeah, bring them back, thinking on the multifunctionality. Thanks.
Yeah, great addition, Berenice. I think this is what we need, and this is also what we are kind of always thinking about working towards. And Anna Maria has introduced this earlier. We need ways also for quantification. We need frameworks that help us make such decisions. It is probably never going to be possible to really create optimal health at all three dimensions because there's trade-offs. There's always going to be trade-offs between these dimensions. And what we need tools, we need frameworks, we need methods to help us make these ethical decisions. And in the end of the day, it is a question of ethics. And one of the elements that we also want to promote is that in One Health, there should be something like One Health ethics also that explicitly go into the direction of trying to negotiate basically the interests between environment, animal health and human health, which is difficult to achieve because of course in the end the human health side weighs heavier. This is usually what happens. And I think that is also one of the reasons why we try to bring it back to the human. Talking about, let's say, the environment, environmental health. Of course, it has some significance in its own right, but how do we convince people to invest in environmental health? How do we invest, how do we get policymakers, how do we get practitioners to invest in environmental health? If we can make the case that those investments in environmental health will have positive feedbacks on human health, on the human economy, on us in general, this will make a case for them to do it. So even though we might understand that environmental health has a value on its own, to make a case for it, to actually create this investment, it is good to show that there is going to be benefits that are going to be felt by us humans also. And I think this is one of those tricky issues in One Health. Okay, what else do we have here? We have one question from COVID in the Tönnies at the meat factory, the outbreak, and how that is related to One Health. I actually don't think that this is a One Health question fully, because it was not really the meat that was the main problem there. It was more of the issue of the working conditions itself. It's a question of food safety. And yes, food safety is to some respect also a One Health issue. So I would not say that this is like a very strong question that needs a One Health answer. I think this is a quite standard approach in food safety in general to be addressed. Anybody else from the group here wants to take one of those questions? Okay, we just got in a new question on soil microbial health. And I think we have Philip Swoboda in our group here, who might be able to take this up.
Hello, everyone.
Yes, you're on.
Can you hear me?
Yes.
Yeah, hi. So soil microbial health is an outlier of my overall field of soil health, because if you relate it to One Health, there is one fundamental approach that the connecting agent across human, animal, and environment is the microbiome. And as we know, in animals and humans, the core of the immune system is the microbiome. So there are some ongoing studies that, for example, outline that the soil microbiome is connected to the human gut microbiome. But this is a field where, again, it's very hard, first of all, to screen the genetic diversity within the soils, because up until now, we can screen roughly 0.5% of all the microorganisms in the soil. And the second thing is then to make the next step to say, how is this microbiome really affecting humans and animals? I mean, this is an incredible complexity of cause and effect, but according to a lot of paradigm shift in environmental health, biodiversity is connected to resilience. So I think there's a very crucial case to keep soils healthy in order to keep biodiversity healthy, in order to make them also disease suppressive. Yeah, but everything else will go beyond my expertise in this field.
Great, thanks for that, Philip. Juliana, I give you the right to talk. I think you probably want to follow up on something about the food system.
Yes, exactly. About the COVID-19 questions in the meat processing plants. I was going to add something about it. I think it's not that the food itself is being contaminated and also transmitting pathogens via foodborne, but also I think the lessons learned from this current pandemic is that how vulnerable our food systems really are. So firstly, we had increased the human-animal interactions by increasing the consumption of animal-based products. So we are accelerating, in this sense, ways of production systems that drive biodiversity loss and environmental degradation. And this is all based on our consumption patterns, and also that how our food systems are actually working as an agricultural bridging of zoonotic transmission. So they are jumping new viruses, new bacteria from the ecosystems, especially from wildlife towards domestic animals and humans. And especially during the COVID-19, we see now how the food system itself is an essential service provider that cannot stop, and it is especially vulnerable and harmed during this pandemic. So the rate of infections occurring within the agricultural sector and also food supply, we see in meat processing plants, but also in workers working like in supermarkets, in the distributions. So it's a special sector that we need to focus on bringing strengths and bringing ways of protecting, especially humans, but also the animals within the system. And in the sense, building resilience in our environment and ecosystems. We need to use this moment of the pandemic to raise new approaches and rethink sustainability and the healthiness of our food systems, and how we can cope to promote the health, not only of humans, but also of the animals and of our planet. That was my comment, and I think it was helpful. Thank you very much.
Yeah, thanks, Juliana. Just to put it into context, Juliana is one of the doctoral students, and she actually looked into how COVID has affected dietary choices also. So if you're interested in that, you can always look at her poster. And of course, she's going to be later on in the panel, so you can address her questions to her directly also at that point. So I'm going to give one last opportunity to ask questions in regard to these country cases. I know it's a lot to take in, so I think it might be now the time for our lunch break. So we're going to take 1 hour off. During this time, feel free to place new questions in the question and answer. If we might be able to answer them directly in written form, or they can already flow into also the panel discussion that's going to be coming up after our lunch break. So we're now going to have 1 hour of break to refresh our minds, to kind of gather our thoughts and also reflect on all the inputs that we have received throughout the morning. And then we're looking forward to welcoming back Professor Zinstag to our panel. We're going to welcome Dr. Krech from the WHO. We have Professor Walter Bruchhausen, who is the professor for global health here in Bonn. We have Sundan Tiwari from ICLEI. We have Dr. Thomas Klaassen from the Landeszentrum Gesundheit, the Center for Health here in North Rhine-Westphalia. And we have 2 of our doctoral students, Juliana, who you just listened to already, and Krupali Patel from India, who are going to give their insights also. So it's going to be an amazing panel after the lunch break. Gather your thoughts. If you have questions already that you would like to be addressed in the panel discussion, use the Q&A function to ask them already during the break. In the meantime, you can also visit, of course, our website. We have the poster presentations where you can get more information regarding the individual student presentations. And we also have there the policy briefs, so you can have a look at the recommendations that were kind of shown briefly now in these country cases in more depth in written form. So thank you all for your attendance so far. Have a good break, and I'll see you back in 1 hour, refreshed and ready for our panel discussion. Thank you very much, and see you soon. Hello and welcome back, everybody. I would like to first of all ask everybody once again to give me a hands up if you're back in the room. Yes, I see lots of hands coming up. Great. Okay, so let me start by introducing our panelists. First of all, I want to point to our 2 doctoral students, Juliana Menetto Gelat-Paris and Krupali Patel. I think, Krupali, you still don't have your video on. Great, it would be good if you turn it on. So first of all, Juliana is one of our doctoral students. She's a food scientist, and she is very interested in sustainable resource management and healthy diets. She is pursuing her doctoral degree from the agricultural faculty under the supervision of Professor Nöhlings in the field of nutritional epidemiology. Her work is focused in the Ruhr metropolis in Germany, and she has a complementary survey that is also going on in Brazil. Krupali Patel has a background in public health from the Indian Institute of Public Health, Gandhinagar, and she's particularly interested in the interactions between animals and humans in disease transmission and also antimicrobial resistance. She is pursuing her PhD from the Mathematical and Natural Science faculty under the supervision of Professor Thomas Kistemann in the field of medical geography. And she's working on MRSA transmission from humans and animals, or between humans and animals via milk and the indoor and outdoor environment. Next, I would like to introduce Professor Dr. Walter Bruchhausen, who is one of the professors also supervising in our graduate school. He is the professor for global health at the Institute of Hygiene and Public Health of the University Hospital Bonn. He's a medical doctor by training, and additionally, he also has a master in philosophy of medicine and healthcare ethics. He has extensive practical experience in East Africa, both as a medical doctor and as a researcher. I also want to welcome Dr. Thomas Klaassen. He is a medical geographer. He works at the Landeszentrum für Gesundheit, which is the Center for Health of North Rhine-Westphalia. He is part of the section working on key questions and international cooperation, as well as prevention and health promotion. Primarily, he works on healthy urban planning and integrated municipal health promotion strategy. Sundanan Tiwari, I'd also like to welcome him. He's a senior program manager for the global projects at ICLE World Secretariat. He is an ecologist and a development professional with over 20 years of experience. He's a systems thinker and he works on building resilience. Currently, he's working specifically on urban biodiversity in India, Tanzania, and Brazil, as well as low carbon development in the Philippines, Indonesia, and Vietnam. I also want to introduce once again Professor Jakob Zinstag-Klopfenstein, who I already introduced earlier on as a keynote speaker. He's a veterinarian by training and also holds a PhD in tropical animal production. He's working for the Swiss Tropical and Public Health Institute in Basel and has been advocating and researching on One Health since the 1990s. He has extensive work in Africa with a particular focus on mobile pastoralists, and he is also cooperating with the Africa One African Science Partnership for Intervention Research. His book, I already mentioned this morning, One Health and the Theory and Practice of Integrated Health Approaches, is one of the big guiding books on One Health. Lastly, I also want to introduce Dr. Rüdiger Krech. He is the WHO Director of Health Promotion in the Division of Universal Health Coverage in Healthier Populations. He has a background in public health and has been previously directing the WHO's work in the Department of Ethics and the Social Determinants of Health. He's a member of the Global Health Workforce Alliance and has throughout his career been an advocate for universal health coverage, health in all policies, and social protection. So thank you all for being here. Thank you for being in this panel. And it is a great honor to have you here. So to start us off, I would like to ask all the panelists to give a brief statement in regard to how do you understand One Health? What is actually this concept of One Health to you? And I would say we start with Professor Bruchhausen.
Yeah, so for me, as somebody coming from the medical faculty, it's very important in One Health that it is on the determinants of health from the physical environment. So it is actually a well-structured and well-argued approach that might even convince medical doctors who are often rather narrowed within their curative sphere that there is more to health and that it can be researched in a sensitive manner. It's also important for me as a second point that it is on both. It is on curative medicine or healthcare services and on the determinants. So it has an integrative force, as can be seen from the classical example of Jakob Zinstag, common vaccination services for pastoralists, for the humans and the cattle. And that's my third point. In this way, it is really something like a role model, how other health issues could be treated in a highly interdisciplinary and combining preventive and curative interventions manner. Thanks.
Thank you. Next, I would like to pass the word to Mr. Tiwari, who's going to give us a more practical vision of One Health.
Thank you. I don't know how practical it would be, but just the way I kind of look at One Health is actually it is an approach about making bold changes at the systemic level, and that is the work that we really try and do through ICLEI. And what I mean by that is, actually well illustrated by a quote by Robert Pirsig. I don't know if you've read his book, Zen and the Art of Motorcycle Maintenance. And I would just like to take a short quote from there, where he says that if a factory is torn down, but the rationality which produced it is left standing, then that rationality will simply produce another factory. If a revolution destroys a government, but the systematic patterns of thought that produce the government are left intact, then those patterns will repeat themselves. End of quote. And so for me, it is not about just tinkering at the front end, but actually making transformative changes at the underlying and fundamental processes that lead to our decisions and those plans. And therefore, if I put it very broadly, it's actually about understanding the system as a whole and recognizing and identifying and recognizing and acknowledging the interconnectedness that exists, but also about changing mindsets across all levels and across all stakeholders. And by levels, I mean levels of government, since most of our work is focused on local governments. And finally, it's actually about making positive change within the whole system and also within the components that actually make up that system. And why, from a city's perspective, where I come from, and this may be the practical side of it, is that cities are centers of power. They are drivers of economies. They are also guzzlers of resources, but they're also hubs of innovation. And therefore, they are a key actor in actually enabling this deep introspection and these transformative changes that the One Health approach actually calls for.
Thank you very much. Next, I would like to pass the word to one of our students, Juliana Paris.
Okay, so yeah, for me, I'm giving like my understanding of One Health. Theoretically, it's bringing the health of humans, animals, and environment all together, but also at the same level. No? I see it as also a holistic and systemic approach involving the interface between human, animal, and environment interactions, and as often used to address very complex health issues that we are facing now in our 21st century, and also collaborative efforts among different disciplines, able to work jointly at different levels, like from international to regional to local, to attain this so-called One Health. But nevertheless, I also must say that during this, as a personal experience during my research in One Health, I encountered a little bit of difficulties in entering to the so-called classical One Health framework, which is used often in the context of zoonotic and infectious diseases. Like AMR is a perfect example that really fits into the classical One Health. But like in my case that I'm studying nutrition and sustainability and animal welfare, I need to go beyond this classical and go towards this extended One Health approach. That's for me is mostly what would mean really One Health. It's still a growing concept, of course. A lot of people might criticize that could be too general or too superficial, but in my point of view, it's also more comprehensive and elevates the other domains of the One Health, often neglected, especially the environmental domain, which is not only seen as a background where the transmission of pathogens occurred, but worth of having its health by itself. Also, there's not only like the ecological environment, there's also built-in environments, social political environments, the urban environments. And that's what our graduate school is really contributing. And I think we need to bring more from these topics of ecological, planetary health, sustainability, well-being, welfare, even of welfare of animals, and to enrich the concept of One Health and contribute to research and to the extended version.
Yeah, thank you, Juliana. Next, I would pass the word to Dr. Krech, the perspective from the WHO side.
Yeah, hello and a very good day to all of you, and thanks for inviting me to this panel. Now, since the millennium, so for the last 20 years, we've seen different concepts emerging: ecological health, environmental health, planetary health, and then this One Health approach. And I think the One Health approach is the most encompassing, most holistic of all these approaches coming in for the last couple of years now. And it's if you look at the approaches, there's a couple of things that are essential. That it's a collaborative approach, that it's multi-sectoral and transdisciplinary. And then second dimension is that you work at the local, at the regional, at the national, and the global levels. And of course, with the health to achieve optimal health by considering that interconnection between people, animals, plants, and their shared environments, of course. So I think that is what I would understand as this One Health approach. And that's why when we then talk about sustainable development goals and sustainability in development at the UN system overall, that's where these different dimensions that I've just tried to explain come into play.
Thank you very much. Dr. Klaassen.
Yeah. Hello, everybody. I hope you can hear me.
Yes.
Yeah. Okay. Yeah. Thank you very much for inviting me. So when I'm thinking of One Health, so in my opinion, it is not only looking at human and environmental health in one region of the world and trying to understand the interconnections between those three health aspects. One Health directly results, just as Mr. Krech told us before, from and substantiates the sustainability approach, which led to the Agenda 21 from Rio de Janeiro in 1992, and its follow-ups like Millennium Development Goals in 2000, the Sustainable Development Goals that we are now facing from 2000. So this means to think global when acting on a regional or a local level. And it means, in my interpretation, to always have a health and all policies perspective in mind, no matter if we are talking about urban or regional planning, environmental planning, animal health, consumer protection, or original public health strategies or measures. So knowing this makes it easier to understand our determinants of health and tackle our main challenges for the future. So actually, COVID-19 pandemic shows us in detail why a One Health approach is so.
Okay, yes, thank you very much. Next on the list, Krupali Patel.
Hello, everyone. So I think what I understand about the One Health is like the One Health is not a new concept. Like before century, people or scientists also pinpointed on One Health somehow, and after century, like after 1600, they also started to talk about it again. But over the period of time in this 21st century, when we face the many outbreaks of many zoonotic diseases, and then we retrieved from history and we revised and we polished, and then we are now focusing on the One Health, and it is already defined in a well manner that we need to focus on human, animal, and environment. But since in the morning we are talking a lot that it is still human centric. Although we want to improve the human health by improving the animal health and environment health, but yes, I agree with Juliana that the environment health is still left behind. Like, and the other concept is like One Health, people are adopting in a practical manner. One Health is like in a feasible manner, and it also varies to countries, and also based on the type of disease condition they have in their countries. If you see the developed world and developing world, then Like for example, in India, the One Health is more famous in manner of zoonotic diseases. Like you want to use the One Health in zoonotic diseases to control the zoonotic diseases. And talking about to control that, I agree with Professor Walter that we can use the One Health as curative manner, but same time we can use the One Health as a prevention and control also. So specifically in the countries where the zoonotic disease burden is high, and there is, I think, still more miles to go to include the environment, because to include the environment extensively practically is so difficult.
Thank you, Gopali. Last but not least, Professor Zinstag, and as we already heard you in the morning and your view on One Health, maybe you can take it not just about your One Health view, but also the added benefit of One Health that you see.
Thank you very much, Timo. That's exactly where I wanted to go. I would like to give you philosophical foundations of One Health. Actually, we would declare health or freedom of disease as a commons in the sense of Elinor Ostrom. You know, Elinor Ostrom is a Nobel Prize in economics for governing the commons. And Elinor Ostrom opposes the tragedy of the commons proposed by Hardins. She says cooperation allows to sustainably managing natural resources, albeit in smaller communities. And I would argue COVID-19 shows us actually the tragedy of the commons in a global way because of the lack of cooperation. So actually we need global cooperation to create benefits for health. We are just one little planet in the whole universe. So that is the philosophical foundation of One Health as added value of a closer cooperation of all health-related disciplines. And we are currently actually developing a cooperative game theory of One Health based on Elinor Ostrom's philosophy of science foundations of governing the commons. So this is the deep-rooted thinking about the idea that One Health must produce an incremental benefit. And maybe just with regard to operationalizing One Health, we are currently analyzing all the international health regulation reports and PVS reports of the World Organization of Animal Health. This is performance of veterinary services reports to see how far has One Health governance really gone in its operationalization. And interestingly, many countries start using One Health in their international health regulation reports and also in the PVS reporting. Thank you very much.
Thank you, Jakob, for your perspective. Throughout the day, you have already heard from us that our graduate school is actually having this urban focus. And very often when we are talking about One Health, the first idea that pops into mind is actually more the rural areas, the agricultural areas, because that is where the interaction between humans and animals is very strong. At the same time, we see that One Health is gaining a lot of traction. It's really a hot topic at the moment. And for this reason, I want to address the question to Dr. Klaassen first. Do you see any integration of One Health in the practice of urban planning at the moment on the regional level? You're still muted, Thomas.
I'm still muted. Okay, now I'm unmuted. So that's not an easy question to answer. So I will really try to answer this question mainly as a health geographer and a public health representative from Germany, and especially for Westphalia, which is my home state. So I've been dealing with practically nature and health interventions, environmental health stressors, and urban public health challenges and demands on urban and regional planning for almost 20 years now. And during the last 9 years, I took the opportunity to have a closer look to rural metropolis, just as you did in your whole program. And I must admit that One Health as an expression with a specific meaning has not played a substantial role in urban or regional planning yet. And the only time that I noted the approach in more detail was a conference actually conducted by the State Ministry of Environment, Agriculture and Nature Conservation and Protection some years ago. Just, you know, far beyond from what you are doing or have been doing as your project. Then there was the Federal Environment Agency, which had some topic going on, but it was not very much. And it was mostly a specific focus on prevention of zoonosis, on antibiotics in animals, drinking water, and food. So One Health as a guiding principle for urban planning is still much underdeveloped. So, but it makes a difference when you focus on healthy urban and regional development. Just look at how urban areas receive higher resilience in the context of urban climate adaptation, regional food production, noise and air quality improvement, or mobility management, health promotion, and last but not least, COVID-19. In this respect, there has fulfilled a new reinterpretation of urban green and blue infrastructures. And these are some of the points that you already mentioned and your colleagues already mentioned in the ongoing conference today. So in the rural metropolis, for example, urban nature development has become a main topic of urban to tackle the challenges mentioned above.
Yes, thank you very much. That was actually my feeling that we're not quite there yet. That One Health is not really at the practical side, especially in the urban areas.
No, so actually we're talking, actually we are talking about, I think, not One Health. Some are talking about sustainability approach, some are talking about resilience, but they're not talking about One Health.
Yes. I think into some respects, One Health is also maybe viewed in terms of health in all policies. And maybe that is something that we see more in urban planning, because when we start to understand that the urban environment has impacts on human health and animal health and the interactions between, then we can start seeing that urban planning can have a significant role as a place of intervention in urban planning. The same question I would pose to Mr. Tiwari, who's going to be maybe looking at this from a more global perspective, into what extent he has actually seen this term One Health pop up in regard to urban planning.
Well, I would agree with what Thomas said and what you just said, that the One Health approach as a whole has not really got integrated into urban planning as yet. But I mean, I would like to suggest that there are efforts that are being made in that direction, sometimes consciously, sometimes unconsciously. And the way the way the One Health is currently being looked at, as you could say, is like the story of the blind man trying to figure out what an elephant is, and touching different parts of the body, and therefore making a decision based on that. So I think what we are seeing in several initiatives in urban areas are different elements and the principles that underlie the One Health approach. And I think the most direct one is through biodiversity, the integration of biodiversity in urban areas. I mean, there's very clearly the strong linkages between improved mental health and general well-being of citizens and access to green spaces and nature. And this is really well established, and now we're increasingly seeing cities around the world rethinking how they use the space that is available to them and how they engage with the space that actually that surrounds them. We ourselves are working with cities in Tanzania, Brazil, and India, the project you referred to initially, in which we are mapping the flow of ecosystem services from hinterlands to the city itself, so that to kind of influence the urban planning processes at the local level, but also to then influence urban policy at the national level, so as to mainstream biodiversity into all these planning and practice processes. So there is using biodiversity as the entry point over here and really highlighting the multiple benefits that and co-benefits that you actually get from doing so. Uh, there are several other initiatives like the loss of pollinators, and where there are these efforts that are really being made in terms of having these little islands, which I think we see around Bonn as well, where to bring these pollinator populations back. So there is that thinking, there is that more direct connections. But I think there are some other sets of activities as well, which are, you could say, are on the path towards the One Health approach. And some of these are like the urban nexus approach that we are looking at, which looks at what are the interlinkages between food, water, and energy. And we have done a lot of implementation activities around this nexus approach in different parts of the world quite successfully. There is also now, which we're talking increasingly about the use of the territorial approach, which actually moves beyond jurisdictions and which looks at how do you do planning which is more place-based and people-centered. So there is a shift that is really taking place. Or you could think of cities actually now also looking at their impact at the global scale, and especially from a climate perspective, and where cities are declaring climate emergencies and establishing net zero emission targets. So where they're actually recognizing that their actions at the local level have far-reaching impacts across economic, social, and environmental sectors at all these levels, right from local and to global levels. So I would just say is that though we have not really integrated the urban health approach into urban planning, but there are a number of promising initiatives and approaches that are there that are very effective platforms for it to take off.
Yes, thank you very much. So one thing that is one of the challenges is that the One Health approach is still very much focused on infectious diseases, and I think that's when we're thinking about applying it in the urban planning, urban transformation context, then we really have to look at the social determinants of health, at the salutogenetic potentials that can be integrated into the One Health approach. So I want to pass a question to Krupali Patel about how the framing of One Health in regard to the context of the social determinants of health can be achieved.
So thank you, Timo. The framing of the One Health for the social determinants of health, uh, uh, I would like to give some example from my study, because I studied the livestock keeper communities and methicillin resistant Staphylococcus aureus. So there, the people who are specifically vulnerable, the livestock keepers for zoonotic diseases and for many other infectious diseases. And the thing is that there was no any specific allocation for their healthcare because they are vulnerable, and there should be some specific program for them so that we can achieve the good health for them. We can improve their health, and by improving their health, we can also uh, break the connection, the transmission route from human to animal also. But the thing is that this is not still uh, in the action from many countries. Some of the examples are available from Canada and other European countries, in Australia also, where they serially focusing on this animal handlers or any occupation, the people who are really working with the animals. But many countries are really neglecting this part. The second example is for the social determinants of health is for the built environment and for the neighborhood, uh, where the people are living with the animals, and sometimes in the country like India, South Africa, African region, and in Asian, where the animals and humans are living in the close context, and some of the houses are with animals, some of are not with animals, but the effect of animal can be seen in the both kind of the neighborhood, like with animal or without animal. and the built environment. Like for One Health, we are mainly as of now, the current focus is on the water, like the mainly for the water and soil, and also for the dust, but the built environment, how these surfaces are creating the carbon dioxide also, and how they are like the pores of the surfaces are becoming the reservoirs for many pathogens, need to be considered for the one in the One Health framing. Like this should be this need to be expand more. And for the economic stability, the for many countries the animals are the main uh, livelihood and the asset for the economy, and the loss of those animals are really creating the economic loss, specifically for the people who are handling the animals. For example, the mastitis in majority of country, and where the hygiene is poor for the animals, there are many animal loss because of mastitis, and the livestock production loss is also creating the question for the economic loss. So I think the One Health is really a good framework where we can adopt the social determinants of health, and we can provide some evidence, and we can include those things in the policies. And Timo, was there any other question?
No, I think you covered it quite nicely. I would
Thank
ask
you.
Juliana if she has something to add, because Krupali was working more on the infectious side, and Juliana is actually working more on the health promotion side.
Okay,
Juliana?
yes. Yes, no, I definitely agree with Krupali, what she said about this health inequalities, and there are specific types of environment and conditions and socioeconomic factors, demographics that can enhance disease. But like giving a little bit of my perspective on non-communicable diseases, like cardiovascular diseases, which is the main cause of death worldwide, and also the social determinants of health play an important role in the rate of these diseases as well. So when we start to dig deep into the complexity of food systems, of food security, we see that, for instance, modifiable behaviors and available resources, such as ecological, social, political structures, play an important role in preventing diseases and promoting health and well-being. And this is the main focus of salutogenic approaches. I think that our graduate school had many research going on this perspective. And I would say like the One Health would offer tools and perspective to allow a more comprehensive understanding. For instance, like resource-oriented approaches such as the urban green and urban blue can promote health and well-being in terms of mental and physical health, as well as supporting urban ecosystems and biodiversity. And like my research, I'm seeing like modifiable behaviors, which can further also be motivated by social environmental resources, like changing of dietary habits towards more healthier and sustainable choices. We can, through an individual decision, act as a collective decision, which can be systemic change as well. And in this sense, we promote less resource-intensive agricultural systems, promote nutritional health, and also reduce the impact on this our environment, and as well on this intense livestock production systems that are decreasing the animal welfare. So we need to broaden a little bit the health beyond the zoonotic infectious diseases, I would say, and use its full potential that it has for seeking collaborative and multidisciplinary approaches that focus not only at the human health as the main goal, but also that includes the health promotion and well-being, the welfare, including the welfare of the animals, and also sustainability aspects of our planet.
Yes, Juliana, thank you very much. And I think you mentioned something very important, animal welfare. And this is something that actually came up also in the previous discussions before the break, about how do we manage the One Health nexus. Is it human health? Is it animal health? Is it environmental health? How can we balance those? For this, I would like to address Professor Bruchhausen. To what extent do you see it necessary to integrate ethical debates into One Health? Specifically on this, how do we value human health vis-a-vis animal health and environmental health?
Yeah, thanks very much, Timo, for the question, because it allows me to emphasize that ethics is, of course, much more than just the approval or clearance by an ethical review board, as this is only on the research process, but we are really also responsible for the theories that we apply, for the results, the interventions that we recommend. And beyond what has been also mentioned now, questions of equality and justice, as they are a general issue in global health, this point of anthropocentricity is really at the core of the ethical issues of One Health. So the reason why One Health was necessary, one of the reasons is really this enormous neglect of what is being called One Health perspectives today during the development of the industrialized nation. So the increasing distancing from human nature. So we could really say that the European Enlightenment that has created this kind of modern sciences is enormously anthropocentric. And this one-sidedness must be in many ways overcome. And it has been already discussed by the junior researchers in the previous session. But we are also quite clear, we agreed that we cannot really exaggerate the counter move. We must find, as you said, something like a balance between this counteraction against exaggerated anthropocism on the one side, and of course also maintaining the priority of human life on the other. So we cannot give up the achievements of the enlightenment of human dignity and so on altogether. And therefore, it's not simply a way for us to transfer human rights to the non-human nature. This would be for various reasons wrong. So, for example, we do not fight for the survival of every individual animal in ecology. We accept that there are animals that are victims to other animals. Or if we speak of a healthy soil, which is quite an important concept, this is, of course, metaphorical language aiming at human long-term survival. So, for example, in itself, desert soil is not less healthy than a soil that can be used for agriculture. But this balance actually is really an intellectual challenge. And that's something we have to struggle with for a long time, I'm quite sure, because it demands these very deep systemic changes that Sunadan spoke about when he mentioned Zen or the art of motorcycling. Yeah, what are we actually dealing with? According to the Lancet Global Health Series, 84% of the world population are religious. So Europe and the Far East are really an exception from a global perspective. And of course, this influences the attitude towards nature and animals. And the monotheistic religions are rather anthropocentric, and others are less. We've heard from Yashovant the example of the holy cows in Hinduism. We have the shamanistic or indigenous American and Australian religions that have quite another attitude towards non-human nature. And in this regard, I really think it is very encouraging that even the strongest defender of human dignity, which is the Pope, demands now a turn to conserving the creation and to ecological thinking. His encyclical letter, Laudato Si, on our common house is very often cited. That is quite astonishing for a religious text. So we are actually in a situation where the old borders are teared down, and where we really have in a global debate also to learn from each other, to learn from other attitudes towards animal welfare in other vegetarian cultures, for example. And I think this is one of the enormous learning processes that One Health also can start in ethical debates.
Yes, thank you very much for this interpretation and telling us about those ethical issues that should be part of the One Health debate much more. I want to pass the word to Dr. Krech. Is there actually, from the very practical side, especially in the WHO, which obviously is focused on human health, any type of discussions in regard to this more holistic view and viewing actually also the value of non-human animals? And following up to this is basically then, do you see any One Health implementation beyond the very classical topics of zoonosis and AMR happening maybe in the future?
Yeah. Yeah, first of all, I'm very happy how the discussion is going, that you're really looking at the broader aspects, determinants, equity issues, and what Dr. Brohausen, you just said about, looking at who could perhaps help us to get this view across. In WHO, let me perhaps just say, we've had wake-up calls before this one of the COVID-19. We had H5N1 15 years ago, we had H1N1 10 years ago, we had Ebola 5 years ago, and now we have COVID. And I would say the world has not listened to these wake-up calls that the world has given us. Therefore, yes, indeed, we are looking very much at this One Health approach because we believe that we might not have another wake-up call if we're not looking at these interrelations between the planet and the human health. We might end up very badly indeed. And let me give you so the risk, because your question was whether there's risks outside of this zoonosis and AMR, which we are, of course, very much working on. Yes, there are. We've identified about 40 other risks that are there that could lead very easily to the next pandemic. Let me give you one example. As you have introduced myself, that I was leading the work on social determinants, but also on ethics before. Let me take you back a couple of years. In 2013, I received a phone call from the journal Science. Science is a quite reputed journal in natural science. And they asked me whether we would be happy with them publishing a journal article, which was done by a researcher called Ron Fouchier and a Japanese researcher called Dr. Kawaka, about the mutation of two virus chains, H5N1 and H1N1. And so therefore, what I'm heading at is that one of the risks, and to show you the vulnerability and the fragility of how we have organized our world, research in genome mutation is one of them, right? So these two researchers with their groups have taken the H5N1 virus, which is highly lethal, but not very infectious, with the very infectious, but not very lethal virus of H1N1. They wanted to see, they claimed, how many mutations in nature it would take to create one of these superbugs, the superviruses. And it took them 4 mutations, by the way. But the question was, because when you then publish this, you actually also give the recipe, how you did it. And so Science, the journal, wanted to know from us whether this should be public knowledge. We then had an emergency ethics committee with those researchers plus others around. And the problem was, of course, that it already had spread. So they had sent it to about 100 peer reviewers. So the knowledge was already in the world. So therefore, there was no point in not publishing this. But then we enforced a moratorium until we look at what should be out in public and what should be researched. Now the interesting thing is that after a couple of years now, last year, these researchers and others take up exactly that sort of research, and they are funded. By whom they are funded? Well, interestingly, not by medical science, but actually by military. And then the second thing is that these things then are, they, at least with a double reason for making that research is not just to get some more insights how vulnerable the world is, but also to potentially use that for bioterrorism. And it takes actually the knowledge of a molecular biologist, a geneticist, and about $30,000 of equipment to create those viruses. So this is another very concrete risk that we're facing. And that's why the One Health approach is not just an approach, but it's also a mindset. And it's thirdly, sort of set of technical tools that we have at hand to really come to grips, to understand what the vulnerabilities and the fragility of this world is, and that it's only through looking at this holistically that we will be able to prevent another pandemic from happening.
Yes, thank you very much. And I'm quite happy to hear that there is these thoughts in the WHO going much beyond, and hopefully we are all going to be able to also contribute academically to finding the evidence required to then make the right political and policy choices. I now want to take a brief look in some of the questions that have been posed from the audience. And there's actually one that Professor Zinstag and Dr. Claassen have already started writing about with the question asker. And I find it actually a quite interesting one, and it's somewhat linked also to the discussion we just had. So we have quite a lot of these interdisciplinary approaches coming up. So we have eco-health, One Health, planetary health. And to some extent, these are all kind of pursuing the same goal, but at the same time, they're kind of distinguishing themselves from each other. So the question that is being asked is, shouldn't we have actually set an example and try to integrate all of those different interdisciplinary approaches to each other, rather than having all of those kind of similar approaches that of course are somewhat distinct from each other, but are all calling for more interdisciplinary work, more holistic views on health and health promotion, and how are we going to deal with that? And I mean, this is whoever wants to take it, go ahead. Dr. Claassen, you're unmuted.
Yeah, maybe I'll just start because I already started answering. Actually, I think there is no problem with having different ways of calling the same goals, if we are talking now about planetary health or One Health, because we have to acknowledge that some of these approaches might come from very different perspectives, very different disciplines. And so these different disciplines, they have different methods that they use to bring in. And maybe it just picking everything together in one big transdisciplinary and interdisciplinary approach could become a problem, because then we have a discussion going on how we deal with these different methods and which method should be better or could be better. And then we might come in a normative discussion, which might not be useful.
Thank you. Someone else have something to add?
I may just add a couple of quick thoughts on that. I mean, I see the point being made, but I think, given at least the way I understand the One Health approach and how broad that approach is, I think the way we look at the implementation of that needs to also have a certain degree of both flexibility and resilience in it, so that you can actually approach it from many different directions where you're working towards the same goal. I mean, tend to be a little not so much in favor of having, just having, in this case, for example, a common disciplinary approach, which kind of tends to be a little exclusionary, if you like. It kind of then excludes people. Whereas what you're trying to say is, at least from our perspective, is that we want everybody kind of coming in and chipping in with their expertise and the knowledge that they bring. So that will just be a different perspective.
Yes, thank you for that.
Go
ahead.
Yeah. So after the Ebola crisis, we had a total transformation in WHO, and we've actually transformed the organization, but also the way how we deal with member states on three major pillars. The first one, and the most important one, is how to stay healthy. And there we see that health, by and large, is created outside of the healthcare sector. And that requires exactly those multidisciplinary, interdisciplinary approaches that you've raised, and working on the determinants of health to actually reduce the inequities that we see all over. The second is how we increase the coverage, so the universal health coverage goal, so that everyone who needs care receives this care without falling into poverty. And the third one is to prevent people from emergencies. So these are the three main pillars of WHO and the Global Program of Work, which is our collaboration with our member states. And so there you can see, therefore, the centrality that this interdisciplinary work actually takes. And so therefore, I would also say that perhaps we need to make a further step in this approach. It's so serious that we understand how different agendas look like, how we can tune in with those other agendas, understanding the logic and the language, the professional language other sectors speak in order to promote health. It's central to public health, and actually I would say definitely also to preventing another emergency, as well as to reduce preventable diseases, and that's very often non-communicable diseases, which by and large are preventable.
Yes, thank you. So looking at the clock, I think we need to kind of start to come towards the end. And I have one more question, which is actually directed at the three of you again, Dr. Krech, Dr. Klaassen, and Mr. Tiwari. And this is actually looking at the implementation and application of One Health. Where do you see actually the need, the kind of the gaps to application, and where can research actually help to overcome some of those barriers? Essentially, what do you need from scientists to help? Who wants to start? On the list, I guess it's Dr. Klaassen.
Okay, then I will start. I just saw that Mr. Krech had still his mic on. So, okay. So I think for better implementation of One Health in urban planning and in transformation, we need to overcome the prejudice that One Health was mainly an environment and animal health topic, which focuses on health protection aspects. Because urban planning and development, and this is what I am speaking for, were implemented to prevent us from harming environmental influences. Yeah, that's true. But it is in charge of development of health promoting strategies and measures too, which take into account the circumstances and the settings people live, work, love, and learn in. And I think you all may now see what I'm going to, because I think we definitely need to better link the One Health approach to the strategies given by the Ottawa Charter of Health. I think this has not been mentioned yet in this whole discussion. Because that was already launched more than 30 years ago, even before the concept of sustainability became the new paradigm of transformation. And in this respect, health could be implemented as, or One Health could be implemented as one major concept for health and all policies approach. And this is exactly, Timo, what you were talking about. I think we need to more focus on One Health as a topic for more health and all policies, and then we can bring it into practice.
Thank you. Mr. Tivari.
Thank you, Timo. I really like this question, what do you need from research? I keep getting that as a practitioner, that's a discussion that we keep having. I'll come to that, but just to say, just in terms of the trends that we are seeing from the different cities who are members of ICLE, and we have over 1,700 members around the world who are serviced by our offices. And what we are seeing is that this pandemic has actually put a huge spotlight on the links between urban planning and the health, especially in this case of citizens. And what we are receiving several requests from our members is how is it that they can really use the current programs that they have, whether it's related to climate change or any other program or activities, and how can they use those to improve the health and well-being of the cities. And you have to say you don't really have all the answers right now, and I think that's one thing where we really need. So the point is that there is a huge opportunity here that we need to capitalize on, and that is where organizations like ours and with researchers like yourselves, we really need to work together and be able to provide some solutions that cities can adopt. Which then brings me to another couple of points, and just to stick back in terms of I think there is a huge need to create once a momentum for the One Health approach, and therefore this approach and the whole concept and thinking around that really needs to make its way into the living rooms of individual households. I mean, you've seen that happen with climate change. You've seen that happen with biodiversity loss. It has become actually a people's movement. And because we work so much with politicians, the mayors, it is everything, the political decision at the end of it has a huge impact. And so you really need to be able to also convince your politicians. And one way of doing it is through the people and the citizens within the cities. On the researchers side, I think one of the issues that we always need, and I think that's probably more broadly, not only specific to the One Health approach, but could be applied to other areas as well, is that we really need researchers to help us with decision makers at the local level, for example, the mayor, to establish science-based targets that are evidence-based, through evidence-based decision making that are actually informed by the One Health approach. How do you actually help the city to set up such a target and then be able to work towards it? And this then does not only mean in terms of undertaking the research, but I think more critically from our perspective is interpreting and communicating those results in a manner that is appropriate for those target audiences. And that is an area of struggle that's been there as to how do we talk, when you work with researchers, how do you communicate those to the policymakers? And I think finally, another opportunity that we see is how do we then embed, we kind of work together in terms of exploring methods and processes of actually embedding the One Health concept into existing approaches, both at the national, local, and global scale. So in terms of the national priorities that we have, say in terms of infrastructure development plans that are there, we know cities in the global south are going to require a massive amount of infrastructure just to sustain themselves and the citizens. How do we build these concepts into these existing initiatives? And at the global scale, there is a huge focus now, say, on achieving the SDGs. And now countries are coming up with, their voluntary contributions in that regard, or their plans in that regard. How do we build it into these existing plans and programs? And I think that's where both practitioners and researchers can really help make a difference.
Thank you very much. Lastly, Dr. Krech.
Yeah, the world is in turmoil, and the reason for that is that the world has not taken the mindset of health promotion as a driving principle or applying that mindset to their policies. So thank you very much, Thomas Claassen, for hinting at the Ottawa Charter, because there the basic principle is that people should be able to cope with the life events they face, and they should be able to take control over their health. Now, what we need is applied science to look at what does this mean in today's world with the transformation, the transitions that we see, for instance, in digital transformations. The innovation cycles are faster and faster. 20 years ago, it was about 20 years. Today, it's 5 years, and researchers tell us it's going to be 3 years for a total revolution of a digital technology. So people can no longer cope with all these transitions. You see this on the day we speak, what's happening in the Western world. And the reason is that it's so complicated, so complex, that people want easy, simple solutions. And of course, they are not to be found. So from a research point of view is to look at how needs health promotion in the future look like when we're looking at these turmoils and these uncertainties in order to take control over my own health. That's an important question, because then when you look at the way policies are done, we need to change that drastically. It's not just after this COVID crisis to just get back to the previous situation, because then we will face a next pandemic. But we will need to fundamentally look at what development means. And for this, you cannot just take economic growth as the major indicator for development, but you need perhaps a different construct, and perhaps well-being is such a construct where, from a health promotion point of view, we can actually feed into that, but many other sectors could actually come together under a big umbrella of well-being rather than health, because their main mandates are different, are not health. Their main mandates might be transport or housing or what have you. But well-being might be a construct that actually would be able to house the various sectors to come together and create a meaningful, value-based approach again for development. So that's, I think, where we need much, much more of your help in research.
Okay, thank you. We will keep this in mind in our current selection round of new students. Maybe there's someone that moves into such a direction. finally, I want to turn this around and pass to Professor Zinstag and Professor Bruchhausen. Where do you actually see the knowledge gaps in One Health from more of the academic side?
Before you answer, I'm sorry, but I need to leave for another.
Yes, we are already going over time. Thank you very much.
UN system. So
thank you very much for taking the time and being here.
Very welcome.
Thank you. So, Professor Zinstag, where do you see the most important knowledge gaps in terms of One Health at the moment?
Thank you, Timo. If I recall you the necessary requirements for One Health and what did I say first? The sufficient requirements. So again, in this conference, most of the people explain why the world is complicated, but very few are really showing the incremental benefits of this cooperation. So there is a dire lack of good case studies that prove that there is a benefit in cooperation. This is the huge gap. And we waste our conferences with people who show how complicated the world is. But we know this, how complicated it is. So I make an appeal to everybody, please contribute good case studies that prove that we save money and we save lives if we cooperate. That's the gap. Thank you.
Thank you very much. Professor Bruchhausen.
Yeah, in the same direction. So I think really our thinking is still not complex enough regarding both natural systems and social systems. And we know a lot of causalities that function quite well in the laboratory, but not in reality. And therefore, I'm also, I would like also to encourage our junior researchers for more case studies that show really the interaction of causal relationships in real world situations. And that concerns not only the natural sciences, but also the social aspect. We've heard this morning from Jakob Zinstag about the distinction between disciplinarity and interdisciplinarity. And so in research, we can divide it. So some people can do basic research and some others do interdisciplinary research. But for institutions, especially small institutions in healthcare, we cannot divide it, the two. And therefore, we have to do research in how much interdisciplinarity we can really demand from smaller institutions without them forcing to give up their core tasks. It might really be exhausting practitioners, for example, to demand too much intersectoral collaboration from them without strengthening the institutions, without additional staff, without additional training. And that's also something we have to look at in our social sciences research in One Health. Thanks.
Okay, thank you very much for those impressions. We are basically now at the end of our today's One Health Day. And I'm very thankful for all of you that took the time to contribute, to the panelists for their opinions and expertise, and also, of course, to all the attendees who provided us with the question, who showed interest. And I think overall what we can see is that there is an increasing interest in creating One Health research, in moving One Health into the reality, and basically creating health promotion and reduction of disease burdens, not just in humans, but also in animals. So from the One Health Graduate School, I'd like to thank you all for your participation. I want to once again draw your attention to our website, www.zef.de-onehealth.html. There you will find some photo exhibitions giving some impressions of the research work that we have done. There you will also find individual poster presentations on the students' work, and also our policy briefs on the individual countries. And this is also the place where we are going to share the slides of today's presentations and the videos. So with that, I would like to thank you very much for being here, for a very interesting and fruitful day. And I'm hopeful that in the future, we're going to have more One Health research, and we are going to be able to create the evidence that is needed to really move One Health into realities across the world. So thank you again from my side. It was a pleasure. And I hope to see you all in person at the next One Health Day, hopefully under different circumstances. So thank you very much again.
Thank you.
Have a nice evening.
Yes, you too. Bye-bye. Thank you.
Bye.
Thank you.